You've been able to enter the room, sir?
I've been able to enter the room,
I
yes.
think you're not on.
Wait, I'll just
You're
change.
unmuted.
I am. Uh, yeah.
Got it. Okay, then.
Great, lovely. Thanks so much, John. Hi, Arun Kasturi here. Can you see, hear me, whatever?
Hello, so we can hear you.
Oh, lovely.
We'll begin very shortly. We're just waiting for the other judge, Dr. Shalini ma'am.
Sure. Can you just read out the order of the participants today?
Yeah, so we'll do that right now. We're going to take a roll call.
Okay.
Okay, is Dr. Sai Srivalli present on call?
Yes, ma'am. I'm here.
Okay. Dr. K. Christina,
Yes, ma'am.
Dr. Rufia Shaista Kana,
Yes, ma'am. I'm here.
Dr. Satyendra Kumar Verma,
Yes, ma'am, I'm here only.
Dr. S.R. Sahar, Dr. Suhas,
Dr. Sahas, you in the participant list, but we're not able to hear you.
Tell him to unmute. Just see if that works.
yeah, I'll give it.
Okay, while he's unmuting, Sai Sri, the order is Sai Sri Valli, K. Christina. Who's the third one?
Rufia Shaista.
Okay.
Okay, then next is Dr. Satya. Dr. S.R. Sahar. We still haven't heard from you. Okay, next Kiran R.
Yes, ma'am.
Sai Kishan Sasikumar Menon. Okay, I don't think I can call.
Yeah, now shall I just repeat what I've got here? One is Sai Sri Valli, second is K. Christina, third is Rufia Shaista, fourth is Satyendra, fifth is S.R. Suhas, sixth is Kiran R, and seventh is Sashi Kumar Menon. Is that correct?
Yes, that is
Okay.
correct.
So we've got the order down here. Yes, okay, great.
We're still not able to hear Dr. Sahas, and Sai Kishan is not on call. I think we'll wait 2 more minutes as we're waiting for Dr. Shah, and then we'll begin.
Okay. Who's the other judge?
Ma'am. She's the professor and vice principal at MS Ramaya Medical.
Okay, lovely.
Joining soon. I think she's in a meeting.
Okay. Yeah, great. Okay. I'm here.
Yeah,
I'm just muting myself briefly. The moment she joins, we'll start.
definitely so.
Do you think you can call Dr. Shalini or reach out to her in some way? I need to go at 12:30.
Yeah, we're calling them right now.
Yeah, thanks.
Good morning, Arvind sir. This is Dr. Anant Ram, Faculty Community Medicine. Shalini ma'am is will join us any moment. She is in another meeting with Chairman sir. She'll join in the next 5-10 minutes.
No, that's fine. I just have a deadline at 12:30. So
Okay.
we need to finish by then. That's my concern.
Okay, sure, sir. I'll inform her then. Thank you.
Yeah, please do.
Dr. Suhas, are you able to unmute now? Dr. Suhas? Dr. Suhas, if you could unmute and just let us know that you're present. Also, is Saikeshan on call?
Yeah, I'm present, ma'am. Due to some issues, I just log into some other laptop. I'm present.
Okay, thank you. Saikeshan?
Yeah, hi. Any progress on this?
So I called Nui ma'am and she texted me back saying, please begin the first presentation. She would take.
I can't hear you very clearly. Sorry.
Called, said that she's beside the chairman in a meeting and she would take 10 minutes and she requested me to start begin with the first presentation.
I'm sorry, man. I'm not able to hear you. You need to come closer to the mic. I'm so sorry.
So is it clearer now?
Much better, much better.
Yeah. I called Shalini Nui ma'am. She
Right.
said she's in a meeting with the chairman. She's sitting beside.
Right.
It would take 10 more minutes. So she requested you to begin the first presentation in her absence and she'll join when she can in the next 10 minutes.
Did she say that? Should I begin
Yes.
then?
Yes, sir.
Okay, then in that case, over to the host. Please go ahead and start the session. Give us the rules and stuff like that. Yeah. Thank you.
All right. Okay, again, I don't think Sai Kishan is on call. Okay, he will join soon. Okay, he has some technical glitches. Okay, so anyways, I'd like to wish everyone a very good morning. Welcome to the 32nd State Level Annual Conference of Karnataka Association of Community Health, hosted by RMC. The theme for this year is Redefining Public Health, COVID-19 and Beyond. So with this, we shall begin with our session for today, which is the Millennium Category Award for both PG and UG. So let us take this opportunity to introduce our esteemed judge on call, Dr. Arvind Kasturi, sir, a professor at St. John's Medical College, Bangalore. We welcome you, sir. It's great to have you on call. And we also will be having Dr. Shalini Nui, ma'am, who is a professor and vice principal at MS Ramaya Medical College. She will be joining shortly. We are thankful to you for dedicating your precious time to judge the session. Moderated by me, Prakriti. I'm a fifth-term student at Ramaya, and
I'm Rahul. I'm a fifth-term student at Ramaya Medical College too.
okay, so we will just go through the instructions for today very quickly. So please make sure, participants, that you have an uninterrupted internet connection. Please make sure you have entered this WebEx meeting under your own name. Make sure your camera and microphone are functioning properly. Make sure you are seated in an isolated and closed space with proper lighting. Please mute your microphones when you are not speaking. Stay seated and stay present and stick to the given time frame. Your presentations will be stopped if you are exceeding the given time. So the time limits for today will be 8 minutes will be given for each presenter for their own presentation, and then 2 minutes will be given for the judges to ask you questions. And
There will also be a reminder at the 7th minute that
yeah.
only 1 minute is remaining.
Okay, yeah. So with this, we wish all the participants good luck, and we can begin now.
I would like to call upon the first registration lady
What I'm noticing is that if you don't speak straight in front of the mic from the host, we can't hear you. So right now we couldn't hear what he said.
Okay. Could you hear me?
Yes, you are very clear. It's just that when somebody's speaking from the side, we are not able to hear.
Now?
So, is it better now?
Much better. Please proceed.
I would like to call upon the first presenter, Dr. Sai Srivalli Sripada, with 29.
Yes, sir. I'm here.
Dr. Sai Srivalli, are you here?
Yes.
Present your.
Yes.
We have presenter. You can go ahead.
Yeah, just a second. Are you able to see my screen, ma'am?
Yes, we
Yes,
are. Please proceed.
Okay, sir. Good morning, everyone. I'm here to present my study on anxiety, obsession, and reassurance-seeking behavior due to COVID-19 pandemic. COVID-19 pandemic has not only seized the body but also imprisoned the mind. This fast-spreading infectious disease has caught widespread awareness, resulting in emotional states like anxiety, distress, which according to WHO are natural psychological responses to the randomly changing state. Studies post-SARS pandemic and post-Ebola epidemic indicate that even after recovering physically from the disease, individuals suffered from social and psychological problems, and similar could be the impact with this pandemic too. Therefore, assessment of unprecedented mental health outcomes has become the need of the hour. With this background, the objectives of my study were to assess anxiety, obsession, reassurance-seeking behavior due to COVID-19 pandemic, and to compare these outcomes among healthcare professionals and general population. This was a community-based cross-sectional study, a self-designed semi-structured questionnaire consisting of demographic details, anxiety, obsession, and reassurance-seeking behavior was used. Informed consent was included at the beginning of the questionnaire. The data was collected through Google Forms by sharing the link electronically. 5 items assessed for anxiety symptoms, 4 for obsession, and 5 for reassurance-seeking behavior over the past 2 weeks on a 5-point Likert scale. The total score of coronavirus anxiety scale ranged from 0 to 25. Obsession with COVID-19 scale ranged from 0 to 20. And coronavirus reassurance-seeking behavior scale from 0 to 25. A total of 527 responses were received. Healthcare professionals included medical undergraduate and postgraduate students, medical practitioners, pharmacists, lab technicians, and nurses from various health organizations working in a designated COVID-19 care facility. General population included other working professionals, college students, housewives, and retired personnel. Ethical clearance was obtained from the Institute's ethical committee. The inclusion criteria was people above 18 years and above age, those who were willing to participate and gave consent, people who had access to social media platforms and understood the content of the questionnaire. Exclusion criteria was people of less than 18 years of age and those who have filled the survey forms incompletely. Data analysis was performed using SPSS version 25. Descriptive statistics are expressed as frequencies and percentages. Chi-square test was used to find out the significance with a p-value of less than 0.05 as statistically significant. The results showed that about more than 53% of our participants were females and 92.40% of them were less than 50 years of age. And majority of them majority of the participants were unmarried. Most of the study participants belong to Hindu religion, and the healthcare professionals were about 48.38%. Out of the total population, COVID positive people were 12.12%, and primary contacts of COVID-19 positive cases were 27.32%. The analysis of the scores was done as follows. A score of more than or equal to 9 on CAS was considered a probable dysfunctional coronavirus related anxiety. Obsession score of more than or equal to 7 on obsession with COVID-19 scale was considered probable dysfunctional thinking about COVID-19. And a score of more than or equal to 12 was considered on coronavirus reassurance seeking behavior scale was considered above average reassurance seeking activity. Out of our total respondents, anxiety was seen in about 2.65% of people, and obsession in 18.40%, and reassurance seeking activity was seen in 9.67%. This shows that the healthcare among the healthcare professionals, there was the anxiety was observed in 1.96%, and obsession was seen in 13.72%, and reassurance seeking behavior was seen in 5.88%. And out of the total general population, 3.3% had anxiety, 22.79% had obsession, and 13.23% had reassurance seeking activity. Out of the total population who had anxiety, which was 14 in number, 35.71% belong to medical, healthcare professionals, and 64.28% belong to general population. Out of the total population who had obsessions, 36.08% belong to medical fraternity, healthcare professionals, and 63.91% of the people belong to general population. And among the people who had reassurance seeking activity significantly, 29.41% belong to the medical, healthcare professionals, and the others were general population. Comparison of CRBS among COVID-19 positive and negative individuals showed that COVID-19 positive individuals had a significantly higher reassurance seeking behavior more than COVID negative individuals, with a p-value of less than 0.05. While several studies have discussed mental health issues during the pandemic, focusing on various sections of people, not many have compared the outcomes among healthcare professionals and general population. In our study, anxiety, obsession, and reassurance-seeking behavior have been observed in a sizable amount of population due to this pandemic, similar to a report by Banerjee et al. A study in Hong Kong during H1N1 pandemic showed that anxiety reached the highest point at the peak of the pandemic and decreased with its decline. India is already past its COVID-19 pandemic peak. Hence, relatively lesser anxiety levels were observed among our study population. In spite of this, obsession and reassurance-seeking behavior is found to be significantly high, showing that coping mechanisms have become more prevalent among the public over time. Latest and most accurate information might reduce anxiety levels to a great extent, and this might also be helpful in achieving a sense of public security and potential psychological
1 minute remaining.
benefits. The major psychological crisis interventions that can be made by health sector is to adequately educate the general public regarding the thin line between taking preventive measures appropriately and being excessively obsessed due to anxiety during the pandemic. Hereby, I conclude by saying that according to our analysis, general population are more affected than the healthcare professionals, since early detection of mental health disorders in individuals at risk can help in providing efficient support to the vulnerable groups. Appropriate psychological interventions can be planned using treatment strategies and techniques to preserve the mental health of individuals. These are the references for my study. Mental health matters. Thank you.
Thank you. Before the judges get started, we would like to introduce Dr. Shalini Sinoi ma'am, who is on call of MS Ramaya Medical College. We hand it over to the judges to. Thank you, ma'am. We hand it over to. Ma'am, we are unable to hear you properly.
Dr. Shalini ma'am, not able to hear you.
For being late. Oh, can you hear me now? No? Okay.
Yes, ma'am. We can.
Yeah, sure. Thank you. I want to apologize to Dr. Arvind Kasturi for being late. I don't know if he can hear.
Dr. Shalini, yeah, welcome. Great to have you. Thank you so much for joining.
Thank you. And sorry for the delay, okay?
No problem. It's just that I have a deadline at 12:30. Never mind. So shall we go ahead and check this presentation?
Yes, please.
Okay. So the presenter, first question to you is, what is this population that you have sampled? How did you get them?
Sir, I have circulated the forms online, sir. So,
okay.
Whoever has responded to my questionnaire, I have taken according to the inclusion criteria, I have taken their responses.
Would there be any problem you foresee by using that method?
Yes, sir. Actually, I couldn't categorize them exactly. It would have been better if I had used some sampling technique. But then since I had to do it an online study, in par with our social distancing measures.
Not so much about categorization. Do you
Yes,
think that this method could kind of introduce some kind of an error in our estimates, and why? If you agree with this.
Yes, sir. There might be some sampling error. I should have taken some.
Why? What is the sampling error that you anticipate?
Defining the population, sir.
Okay. What about defining the population?
The
Okay, never mind.
categorization,
Shivali, no, let's pause. We don't have too much time. Let's just
Yes,
move
sir.
to your slide. You had a figure 2B and a figure 2A in your
Yes, sir.
results. What's the
Yes, sir.
difference between? Why did you have which is the better one? Which
Figure
directly
A, sir.
leads to your conclusions? 2A or 2B?
2A, sir.
Why did you include 2B? What is the information that 2B gives us?
I just wanted to see how many numbers belong to the medical population who had anxiety in our population.
But do you think that's a useful way of looking at it? That is, out of the people who are anxious, how many are medical professionals and how many are not? Or 2A, which is out of the medical professionals, how many are anxious? Which is a better way of representing the data?
Out of the medical population, how many had anxiety? That
Yes,
was
so I
the
didn't
better
really
way, sir.
see the point in 2B. Discussion. I saw your first point in discussion. I mean, is it actually when we do this, I would request all of you to keep your presentations on till we finish this question and answer thing, because then we can
Yes,
refer
sir.
to the slide that we're talking about.
Yes, sir.
So,
I am just presenting it, sir.
but how are we doing for time, hosts? We have only 2 minutes for this, no? Yeah. Now, in your discussion, the first slide of discussion.
Yes, sir.
Yeah, and I look at your third point, I think, where you showed that anxiety reached the highest point of the pandemic and decreased with decline. We are past, and therefore lesser anxiety was observed among our study population. For you to say this, did you have any evidence to say that there was more anxiety in the earlier part of the pandemic?
Yes, sir. I have seen few studies where medical population had higher anxiety levels because they were more exposed, more directly in contact with COVID-19 patients. So there were two studies, sir. One in Wuhan and also the other one in Visakhapatnam.
The last question of the conclusion. Let's just go to your conclusion slide.
Yes, sir.
The first conclusion. It has a significant effect on mental health of individuals from diverse groups. General population is affected more than healthcare professionals. Now, do you think this conclusion is justifiable from this study?
Yes, sir. According to my analysis, I have found that, statistically as well, significant was the anxiety, obsession levels and reassurance seeking levels in general population that I have considered as compared to healthcare professionals.
Okay, great. Thank you. Dr. Shalini, if you have anything.
No, these were the points that I also wanted to ask, so we can move on to the next one.
Okay, thank you.
Thank you, sir. Thank you, ma'am.
Thank you, Dr. Sai Shivali, for the wonderful presentation and the judges for those insightful questions. Let's move on to the next presenter, Dr. K. Christina, with registration ID RMC Kach 0150.
Good morning.
Good morning. All the best.
Thank you. Can you see my screen, please?
Yes, we can. Please continue.
Okay. May I start?
Yes, you can start.
Good morning, respected judges and audience. The title of my paper is Clinical Profile and Outcomes of COVID-19 Positive Patients, a Cross-Sectional Study. Coming to introduction, COVID-19 was first reported in 31st of December 2019 And globally, there was increase in cases by 8% and deaths by 21%. The case fatality was reported highest in Italy and lowest in Germany. Overall, it was 3.4%, and nearly 20% belong to 80 years of age. And in India, the total number of cases till date are 10 crore 75,116, and with resulting in 1,46,000 111 deaths respectively. So the clinical presentations are diverse from each country, and the most important common symptoms are fever, cough, and mortality rate was uncertain. The severity was higher among the elderly population and those with comorbidities, and they had increased chances of mortality and morbidity and ICU admissions. So the objective of my study is to know the clinical profile and outcomes of COVID-19 positive patients owing to the novelty and authenticity of the diversity of this COVID-19 globally and especially in India. The study consisted of a community-based cross-sectional study among the COVID positive patients who were tested either by a rapid antigen test or RT-PCR, either by throat or nasopharyngeal swab. A total of the four field practices area under Department of Community Medicine has been taken, consisting of 727 sample size. The first case, which was reported late in April, in the month of April 2020, until November 30th, the cases were taken. And all the cases were taken from the field practice area, were line listed as per the Belgavi district COVID positive patients list. And after obtaining written informed consent from the participants, they were interviewed using a pre-designed pre-tested questionnaire. The details such as social demography, medical history, exposure history, underlying comorbidities, signs and symptoms, clinical features, and outcomes were taken. Ethical clearance was obtained from the Institutional Ethics Committee. The statistical analysis used was R version 4.0.2 and Microsoft Excel. Continuous variables were represented by mean plus or minus standard deviation and categorical variables by frequencies. And to check the association, Monte Carlo simulation was used. And to check the variables affecting the outcomes, multinomial logistic regression is used. Cox proportional hazard is used to find the variables affecting the mortality. Coming to the results, table 1 shows the social demographic details of the participants, which shows that most of the participants, nearly 42.64%, belong to the age group of 21 to 40 years of age, and it has male predominance of nearly 60%. Most of them were educated up to secondary schooling, and coming to health professional, nearly 5% were health professional who are affected. Others include agricultural laborers, students, etc. And most of the participants were belong to socioeconomic class 4 according to modified BG Prasad's classification, and the mean age among the participants was found to be 23.52 to 58.42, and it was also observed that only 6.46% of the participants only had health card, so health insurance. Coming to table 2, which shows the relationship between outcomes and other variables. Here, the outcomes studied were complications, cure, and death. As we see, with increase in age, the risk of complications and death also increased, and the cure rate was better among lesser age groups. And the patients who had previous family history of comorbidities are also have increased chance of complications and death. Those with comorbidities and on medication have increased chances of complication and death, and those with a history of smoking, alcohol, and those who are asymptomatic and home isolated have increased chances of death as compared to their counterpart. Among the treatments given, antivirals have increased, it was shown that they have increased chance of complication and death as compared to antibiotics, which showed a better cure rate, and also antibiotic and antivirals steroids have also been used. So by this ANOVA, there was significant difference between age over outcomes, and hence even the Tukey's test for post hoc analysis has been proved that cured with complications and cured with death also showed a p-value significant of 0.05. Coming to table 3, where multinomial logistic regression was used comparing 3 outcomes, and here the values, the results are interpreted in terms of log of odds. As we can see, with an increase in age, with every unit increase in age, the risk of complication also increased, and those with comorbidities had increased chance of death. And those who are asymptomatic had increased chance of complications and death. Same goes with the hospital isolated patients. Coming to treatment history, the patients who were on antiviral therapy had increased logs of complications and death as compared to reference, that is antibiotic, antiviral, and steroids. And those with antibiotic here showed an inverse log, that is decrease in the death, which was proved to be significant. Table 4 shows us the Kach's proportional hazards model, where patients who were previously on history of medication for any comorbidities have an hazards ratio of 2.7491 compared to those who were not on medication, and those who were symptomatic has had a hazards ratio of 3.6446 as compared to asymptomatic. Figure 1 also shows the forest plot of the hazards ratio, where we can see that those who are on medication had an 2.75 increased risk of death, and also those who are having symptoms have 3.64%, 64 times increased risk of death as those compared to asymptomatic. The other variables were not significant. Coming to discussion, it is seen that older age, positive family history of NCDs, comorbidities, and those on medication have increased chances of complication, and the most common comorbidity observed was hypertension and diabetes, which was in par with the other studies, and those with previous history of medication and symptoms have also increased risk of death. Total 28 deaths were recorded, which were also similar to the other studies. To conclude, though 56% of the participants were symptomatic, the symptoms was less severe and improved with medication, and death was found only in 3.85%. Fever noted in 15%, gastrointestinal symptoms in 1%, respiratory symptoms in 14%. The participant with older age was significantly associated with complications, and those with comorbidities were death. So significant association was found between age, family history, and medication history, and so. And participants who were already on some medication had 2.75 times increased risk of death, and symptomatics had 3.64 times increased risk of death. The limitation was we had only included
your time
lab
is up. 8 minutes are up.
Yeah, and there were chances for recall bias. Recommendations are, apart from the regular measures, we can also advise for reverse quarantine. Thank you.
Okay, thank you for presentation, Dr. Christina ma'am. We hand it over to the judges for their questions.
Dr. Shalini, perhaps you can start off.
Sure. Okay. Thank you. Christina, I was a little surprised with the title. You say it's a cross-sectional study, but then you have done hazards ratio, Cox proportional hazards ratio, and things like that. So really a cross-sectional study, or did you look at the records and was it a retrospective cohort study? Actually interviewed the patients?
I have actually interviewed the patients, ma'am. The only positive thing here is whenever the patient was positive in our this thing, like the reports have been gone to the taluka level and district level. So the moment the patient is positive, the patient has been tracked by the ANM till their outcome.
Yeah.
So that
okay,
itself.
But you haven't given methodology clearly, isn't it?
Yes, ma'am. Because of the slight constraint, I couldn't give. But the thing is, yes, ma'am.
Okay, continue.
Yes, ma'am. So the patients, like whoever had an outcome, were interviewed by me, and then their social demographic and all the various other variables were taken from the patients. And also, in case of death of the family member, then the family members were interviewed. And in every health center, 2 of the healthcare workers were trained so as to review the
So you
records.
had only one meeting with them, or did you look at the records and up?
Yes, ma'am. So those patients who had come to my health center with their records, or those whom I could approach with the records, which I could get the records, I had taken it then and there itself. If not, the two healthcare workers had retrieved the information for me.
All right, it's all right. Thank you. And just a comment is your it should be ordinal, you know. It's all
Yes, ma'am.
sort of not in the order, in order, especially education, socioeconomic status is okay.
Okay, ma'am.
Secondly, in the discussion, there is a lot of repetition of results. Could you explain table 3, please? Because if it is not, if you're not following up the patients either through the record or through interviews, I don't know how you can get hazards ratio.
Table 3. Table 3, no, ma'am.
Yes. Not table 3. What's the next table? The Cox proportional hazards and the forest plot.
Yes, ma'am.
How about forest?
Yes, ma'am. So the forest plot is similar to the hazards model because I have just taken only the medication. Actually, ma'am, we had compared almost nearly 17 to 18 variables, but those who are significant only I have put up in my slides. So those who are on medication, meaning those who had hypertension or diabetes or any other comorbidities and were on medication, such patients were at increased risk. Can you hear me, ma'am?
Yes, now I can.
Yeah. So such patients were at increased risk compared to those who are not on medication and those with symptoms. And these tables do not contain the complications. Here, complications were since there were too many. We had yes.
Okay. That's okay. Thank you. Dr. Arvind, please go ahead.
I really don't have too much more. I don't think we have too much time available to ask questions. But Christina, this study, when you say cross-sectional, you interviewed these people at one time. Is that correct?
Yes, sir.
So then, how did you get complication and death as outcomes?
Yes, sir.
Exactly.
So the patients at my data collection period was only for 2 months. Sir. So what has happened is and my limitation was also recalled by us. So a patient who was positive in the month of July and has recovered. So even that patient was under my study. So those who were positive were included in the study. The patients were not symptomatic at the time of my data collection, sir. They had some outcome, whether it is death, whether they are cured, whether they are, have some, whether maybe just that, whether they have a hospital.
Okay, Christina, I think that should do. Thank you.
Yes,
Thank you very much. We understood what you're saying.
Thank you.
Thanks. Back to the host.
Thank you. Thank you, judges. Although we're having a very wonderful discussion in a Q&A session, unfortunately, due to time constraint, we'll have to stick to the time limits for 2 minutes. Calling on the next presenter, Dr. Rufia Shaista Khanum, with registration ID RMC Kach 0210.
Yes, I'm here.
All the best, ma'am.
Dr. Christina, can you stop sharing?
Yes.
I have still not got the option of sharing. Yeah, here it is. Is my screen visible? Still loading. It is, yeah, it's visible. A very good morning to one and all present here. I am Dr. Rufia Shaista Khanam from the Department of Public Health and Community Medicine from JSS Medical College. My topic is knowledge, attitude, and practices towards COVID among Ayurvedic practitioners in Karnataka, India, a cross-sectional survey. Coming to the introduction, COVID-19 is an emerging respiratory tract infectious disease caused by SARS-CoV-2 infection. It was first detected in Wuhan, China in December 2019. And this is not the first time that COVID is known to have infected humans. In the past, there have been outbreaks like MERS and SARS, which has caused a huge impact on the population. Since India has historical roots of Ayurveda and Ayurvedic practitioners also play a major role in the health system, their knowledge, attitude, and practices are important and relevant during such public health crisis. With this context, the study was conducted to assess the knowledge, attitude, and practices among Ayurvedic practitioners. The objectives of my study are to assess the knowledge, attitude, and practices towards COVID-19 among Ayurvedic practitioners of Karnataka, India, and to find out the association between their level of education and the knowledge scores. Materials and methods. The study design used was a cross-sectional study, and the study tool was a online questionnaire that was developed and circulated through Google Forms. The questionnaire contained of two parts, one assessing the socio-demographic details and the other one assessing the knowledge, attitude, and practices. A total of 32 questions were there, out of which 13 assessed knowledge, 10 assessed attitudes, and the remaining 9 assessed practices. Study place was Karnataka. Sample size, considering the prevalence to be 50% as it is a new disease and with the confidence interval of 95% and relative precision of 10%, a sample size that had to be studied was 100. As we obtained more than 100 responses, that was we obtained 127 responses and all of them were included in the study. And the statistical analysis was done using SPSS version 25. Results were expressed as percentage, mean, standard deviation, and chi-square. Statistical significance was considered for p-value less than 0.05. The results, mean age of the participants was 30.5 plus or minus 9.1, and around 68%, 69.3% of the participants belong to the age group 20 to 30, 20.5% of the participants belong to the age group 31 to 40, 3.9% belong to the age group 41 to 50, and 6.3% of the participants were aged above 50 years of age. And 76.2% of the participants had completed their BMS, and 23.8% had an MD or MS in Ayurveda. And 47.5% of the participants were males, and 52.5% were females. The mean knowledge scores was 10.5 plus or minus 1.9. Thus, 86.6% of the participants had good knowledge. And then the association between the education and knowledge scores. There was a significant association between the education and knowledge scores, as those with the BMS degree had 82.7% of them had good knowledge, and all the MD and MS in Ayurveda had 100% knowledge about the disease. Coming to the discussion, the findings were consistent with the study, with other studies like Saklen M. et al. And Richa et al. Among healthcare workers, where 93.2% and 82.15% of the participants had good knowledge scores toward COVID-19, respectively. Similarly, a study conducted by Zhu et al. Among healthcare workers in Henan, China, showed 89% of their participants had sufficient knowledge. Conclusion: good knowledge towards COVID-19 was seen among the participants. Majority of the participants want Ayurveda to be considered as a complementary medicine for COVID-19. But before that, evidence-based treatment protocol needs to be developed to support claims regarding treatment and prevention of COVID-19. Measures regarding training of Ayush doctors in infection prevention and control should be taken, as this may ensure better preparedness amongst them. And the recommendations: as our study lacks complete representativeness due to its online nature, more studies are warranted to investigate the gap towards COVID among Ayurvedic practitioners. The limitations of our study were most of the attitude and practice questions couldn't be scored as they were subjective, and the study cannot be generalized to all Ayurvedic practitioners because it was convenient sampling that we utilized here. And here are my references. And thank you.
Thank you for the wonderful presentation. We now invite the judges to start the Q&A session.
Okay, if I may begin the session. Your sample size calculation equation
Yes, sir.
is Z squared into PQ by D squared, which got you a sample size of 96 actually. If you take 10% and 95% confidence and 50% to be your P, the what you will actually get is 96 or 92, but you included 127. Now, when you use this sample size calculation, what is the sampling method that you're expected to use? Do you know?
No, sir.
Okay, never mind. Now, how did you identify the Ayurvedic practitioners in your methodology?
Sir, I have completed my BMS, so I circulated the Google Forms amongst my network of friends and other, faculties and professors whom I had known. So I circulated it via WhatsApp and Facebook, and I shared the links, and I further asked them to share it amongst their network of Ayurvedic practitioners.
Yeah, well, that's important to include in your methodology because it's important to know how you identified your study group. Okay, then you have in your results you have defined a variable called good knowledge. Now, what is good knowledge?
Our mean knowledge was 10.5 plus or minus 1. Anything above the mean was considered to be a good knowledge, sir.
Anything above the mean was considered to be good knowledge. Now, is that
Yes.
okay? I mean, do you think that that's a fair way of categorizing good knowledge? Because I may argue that unless if somebody knows everything about this disease, it's not called good knowledge. Just the mean
Yes,
score,
sir.
if you pass 50%, then that's good. Is an arguable thing, right? So
Yes,
I
sir.
don't know whether you can categorize knowledge as being good. You can only probably use the actual scores and say this is what they actually scored and leave it at that. Because I notice your association table also has dichotomized knowledge into good and bad.
Yes.
Attitudes and practices, I wanted to ask you, what about them? I mean, in your limitations, you've said that they were largely subjective, but attitude is a subjective thing. So there is a way of analyzing attitude as well. How did you collect attitude?
Sir, there were questions like whether we can fight this COVID pandemic and what were their thoughts. Well, about the questions included something like their thoughts and opinions. So I couldn't score them because everyone has a different thought and opinion. There was only one question that could be scored, like whether India can get, you know, can surpass this pandemic or no, with options yes or no. So
Yeah,
those
okay,
who answered
I
yes.
understand that, but that presupposes that in your mind, the only way of analyzing information is to score it. If
Yes.
there is information which is not scoreable, that information is not analyzable. Is that
Yes.
correct?
Yes, sir. Yes, sir.
Well, I think you need to relook at that assumption because it is possible for you to analyze qualitative information as well of the kind that you've collected on attitude. It's important. The question you asked is extremely relevant. What do you think we can do this? What is your opinion? What is your feeling? We must not belittle that information as it's not scoreable. I think that is something, Dr. Rufia, that you might want to look at as you go on.
Sure,
Right?
sir. Sure, sir.
Thank
I
you.
got that.
That's it from
Thank you.
me. Thank you. Host, that's it from me.
I have one question.
Yes, ma'am.
Actually, so there are a lot of probably because you have your class
Yes, yes.
selection bias in this, in your selection
Yes,
of
ma'am.
sample. How,
Yes, ma'am. Yes. Because it was a convenient sampling and I shared it
is
amongst,
there a method to avoid it?
uh,
Okay, thank you.
yes, ma'am. But I am not pretty. Okay.
No
Thank you.
problem. Thank you.
Thank you so much, ma'am.
Thank you, judges. Let's move on to the next presenter, Dr. Satyendra Kumar Verma, sir, with registration ID RMC Kach 0211.
Yes, sir.
All the best.
Is my screen visible, sir?
Yes, it is visible. You may begin.
Good afternoon, one and all. Myself, Dr. Satyen Kumar Verma from JSS Medical College, Department of Community Medicine, School of Public Health. My topic is knowledge, attitude, and practice towards COVID-19 among healthcare workers in Karnataka only. So, coming to the introduction, COVID-19 is a public health emergency of international concern affecting over 213 countries and infecting millions across the globe, and also affecting the economic worldwide. India has the highest number of cases in Asia. Therefore, all possible preventive actions should be taken to control to spread the infection. This study was conducted in healthcare workers, and they are frontline warriors in fighting this pandemic, and their knowledge, attitude, practice towards the disease are valuable. My objective is to assess the knowledge, attitude, and practice towards COVID-19 among healthcare workers of Karnataka, and to find out the association between occupation and knowledge, attitude, and practice score among healthcare workers of Karnataka. Method and materials. The study design is a cross-sectional study, and study duration was 15 May to 2nd June 2020. Study tool was data was collected through the Google form, which has two parts. First part was consist of social demographic profile, and second part related to knowledge, attitude, and practice. Google form was sent to healthcare workers through the social media like WhatsApp, Facebook, and Gmail. Further, they were asked to share it among their colleagues and friends in the same period. My sample size was assuming the prevalence of assuming the prevalence of knowledge. Assuming the prevalence of knowledge about COVID-19 to be 50%, sample size was calculated with a 95% level and 10% relevance precision. The sample size to be studied was calculated by using sample size formulas, single proportion. Minimum size was 100. More responses were obtained, all were included. Result, the mean among participants was 30.7 plus minus 9.3 years. In the present study, mean knowledge score is 5.86 plus minus 1.32, and mean attitude score is 6.48 plus minus 0.93, and the mean practice score is 4.60 plus minus 0.79. 95.7% of the participants have knowledge and attitude, where 90%, more than 90% have practice towards COVID-19. Coming to distribution of participants based on socio-demographic profile, more than 53% were male, and 46.3% were female, and 39.1% of the participants were doctor, and 46.9% were paramedical staff, and 14% participants were nurses. Coming to age distribution, 60.9% participants were 20 to 30 years, and 18.9% participants were 31 to 40 years, and 14.8% population participants were 41 to 50 years, and 5.4% of participants were more than 50 years. Coming to association between occupation and knowledge, attitude, practice is significant. 55.7% doctors have good knowledge, and 65.2% nurses have good attitude. Even 84.4% paramedical staff have good attitude and practices. Coming to discussion, this finding were consist with the study concluded by M. Thaklin et al. In Pakistan and Richa Nepal et al. In Nepal. Among healthcare workers, where 93.2% and 82.15% of the participants had good knowledge score towards COVID-19 respectively. Similar a study conducted by Minjo et al. Among healthcare workers in Hena, China shows that 89% of healthcare workers have sufficient knowledge, and about 85% them fears of self-infection with the virus, and 89.7% followed correct practice regarding the COVID-19. Coming to the conclusion, the healthcare workers of Karnataka have good knowledge, positive attitude, and good practice To further improve their preparedness and responses towards infectious disease and pandemic, mandatory training program can be introduced. As such, program enhance knowledge and boost confidence among healthcare workers, which is very crucial in the medical as well as public health emergencies. Recommendation: our study lack of complete representativeness due to its online nature, and the study, thus more studies are required to investigate the case study towards COVID-19 among healthcare workers of Karnataka. My limitation is our study lack of complete representativeness due to its online nature. No standardized and validated tool for data collection was used. My references. Thank you, one and all.
Thank you, sir, for the presentation. Now we move on to the judges for the Q&A.
Dr. Shalini, go ahead.
Okay, thank you. I just wanted to ask, what type of sampling have you used?
Convenient sampling, ma'am.
Convenient. Have you heard of something called snowball sampling? Could it be that?
Yes, ma'am.
Why? Why do you say that?
Because I have shared with my other colleagues, so they send to other friends. So it's
Yeah.
them
So
also.
therefore, I think even the title you may have to change. You can't just call it KAP in Karnataka. You can't generalize it to all the healthcare workers in Karnataka, right?
Yes, ma'am.
Isn't it? Yeah.
Yes, ma'am.
Okay. And another thing is, how was the sample size decided? You said something, you had the prevalence earlier, or no, sorry, this is about KAP. How did you decide the sample size?
Z square P 1 minus P divided by D square, ma'am.
All right. Okay. And just please put up your pie chart on gender. I think there was a small error in that.
Yes, ma'am.
Yeah. Do you think that's right? Pie chart gender. Do you think it's right? Okay. Doesn't matter. Just have a look at it later on. Okay. Thank you. Dr. Arvind, please ask.
Just go to the slide before this one.
Yes, sir.
Yeah, now, look at the third bullet. 95% of the participants have knowledge and attitude, whereas 90.3% have practices. What do you mean by that? What about the remaining? I mean, the rest of them.
So compared to this one, 90% they have good practices. So other people they have less practices compared to the 90% population.
So I think the word missing there in your analysis would be the word good, I guess. 95.7% of the participants have good knowledge and attitude, and 90.3% have good practice. Is that what you're saying?
Yes, sir. Yes, sir.
Okay, so that word is missing. Now, good knowledge, good attitude. You've also actually, unlike the previous paper, which is also, I guess, from your institution, because I think I saw the same presenter's name on your list of authors. Is that correct?
Yes, sir. Yes, sir.
Okay, so unlike the earlier presenter, you have defined good attitude and good practice. How did you define that?
Scores, sir. I have done these scores now. I have compared that.
No, what is the meaning of good attitude?
Sir, scores among them, whatever outcome we have got. So if we compare, then we can say that above than mean. So we can say that that this much participants have good knowledge and good attitude.
Okay, that's enough. That's it from me. Thank you. Back to the host.
Thank you, sir. Thank you.
For that insightful discussion. Let's move on to the next. with registration ID RMC Kach 0246. All the best, sir.
Thank you. Hello, I'm audible. Hello.
Yes, sir, you are.
Okay. Good morning, respected judges and audience. My topic is safety and clinical efficacy of a post-exposure prophylaxis in animal exposures. Coming to need for the study. Coming to need for the study, the demand for safe and effective rabies vaccines as well as rabies immunoglobulin for post-exposure prophylaxis is ever increasing. In this regard, many private pharmaceutical companies have started manufacturing the rabies immunobiologicals and are available in the market. There is a need for the periodic reinforcement of safety and efficacy of currently available rabies immunobiologicals for post-exposure prophylaxis. More so, as newer anti-rabies vaccine and rabies immunoglobulin are available in the market. Coming to objective, to assess the safety and the clinical efficacy of rabies immunobiologicals for post-exposure prophylaxis. Coming to methods, the study was conducted after getting the clearance from Institution Ethics Committee, Kings, Bangalore. Study place was anti-rabies clinic, preventive medicine unit, Kings Hospital and the research center. Study subjects were all the animal-wide cases coming to anti-rabies clinic for post-exposure prophylaxis. The study period between January to September 2020. The sample size was 312, all patients during the study period. Study design was a prospective study. Written informed consent was obtained from all the study subjects. The socio-demographic characteristics of all the patients was recorded in detail along with the details of exposure. A complete post-exposure prophylaxis was provided to all the patients, which included thorough wound wash with soap and water to remove all the virus if it is there, full course of anti-rabies vaccination to induce antibodies against the virus, local infiltration of rabies immunoglobulin into and around all the wounds for neutralizing the virus. All the local and systemic adverse drug reactions, if any, was recorded and treated simultaneously up to day 28 as the patients came for subsequent doses of vaccination. Subsequently, all the study subjects were followed up through telephone contact and wherever required by house visits to confirm their survival status 6 months after receiving post-exposure prophylaxis. The data was entered in Excel sheet and analyzed by using a descriptive statistics like a frequency and percentages. Coming to results, the table 1 shows the socio-demographic characteristics of animal bed victims. The present study included 312 subjects, 68% of males and 31% of females. Among them, 30% were children and 44% are adults, and 24% were elderly. Most of these study subjects were literates and belong to middle class of socioeconomic status. And coming to table 2, majority of the study subjects were exposed to dogs, that's almost 93%, followed by cat, monkey, and other wild animals. 80% of the exposures were on the extremities, that is on the upper and lower limbs, and were 45% are abrasions, and pets with 37% are lacerations, and 16% are punctured wounds. Coming to table 3, that is post-exposure prophylaxis provided at the anti-rabies clinic. During the study period, all the subjects had category 3 exposures and were provided complete post-exposure prophylaxis at the anti-rabies clinic. That is, all the subjects were made to wash their wounds thoroughly by applying the soap and clean under running water in the wound wash room. And subsequently, the first dose of anti-rabies vaccine was administered to all of them by intramuscular route with the different brands of available vaccines. Likewise, all the study subjects who had category 3 exposures were explained regarding the different types of passive immunization available in the market and were given as per their choice. Majority, 76% of them received rabies monoclonal antibody followed by equinorabies immunoglobulin and human rabies immunoglobulin. In the majority, 93%, the passive immunization was infiltrated in and around the wound to neutralize the virus at the wound site. All the patients were given injection TT, anti-inflammatory antibiotics to prevent any bacterial infections. Coming to table 4, that's adverse drug reactions following post-exposure prophylaxis. 8.9% of the study subjects had mild local systemic adverse drug reactions which are subsided without any complications. Coming to clinical efficacy of a post-exposure prophylaxis, all the study subjects were healthy and alive at the end of 6 months after receiving a post-exposure prophylaxis, proving its clinical efficacy in preventing rabies. The limitation of the study, the immunogenicity, the ability of the vaccine to induce immunoresponse was not done due to cost of feasibility. All the biting animals to know their disease status were not followed up because of logistical issues. Coming to conclusion, the currently available immunobiologicals for post-exposure prophylaxis, that is anti-rabies vaccine and rabies immunoglobulin, that's rabies monoclonal antibody, were found to be safe and clinically effective in preventing rabies. Thank you.
Thank you, Dr. S.R. Swaz. I would like to request the judges to
Dr. Arvind, please start.
Thank you, Dr. Shalini. Your title, I noticed, doesn't have the word rabies in it, does it? Let's go to the title slide. Yeah, safety and clinical efficacy of post-exposure prophylaxis in animal exposures. It'd be nice, perhaps, if we include the word rabies, because your focus is on rabies here. So that's missing in the title. That's an observation. Just go to your objective. Okay, so rabies immune biologicals for post-exposure prophylaxis. I guess the most important question here is we are unsure of the infection status here. No, in the sense that it is following an animal bite, correct? But when we say it's 100% effective against protecting against rabies, we do not know how many of them. I mean, I saw that in your limitations, you are not following up with the animal to see whether the animal is actually infected with rabies virus or not. So, is it justifiable to say that these biologicals are 100% effective in preventing rabies when we do not know whether the rabies infection was there in the first place? What is your comment on this?
Sir, actually, we were followed up by the telephone contact here. Till the day 28, the patients were coming for the respective next doses of the vaccine, sir.
No, I'm not asking about that. I'm asking, we do not know how many of your 312 people were actually exposed to rabies virus. Yes or no?
Sir.
So I'm saying that, therefore, when we say this is 100% effective in preventing against rabies, we are assuming that in the presence of infection, it is preventing or not. Suppose the people were not infected in the first place. All these animals assume they were animals who were free of rabies. They just bit them as provoked bites, as an animal reaction to a provocation. Then how can we say that this is 100% effective in protecting against rabies when we do not know whether rabies was there in the first place? Is my question. If you understand, Dr. Suhasa. Okay, Dr. Shalini, go ahead.
Yeah.
Yes, ma'am.
So,
Yes, ma'am. Actually, we captured that adverse drug reactions that's immediate and delayed.
there vaccines and biological an association between the side effects and the vaccine. I'm sorry, I couldn't get you. All right, no problem. Thank you.
Actually, we treated in hospital free of cost, ma'am, because our hospital is private.
Any relation between the type of vaccine and anti-sera and the adverse effects? That's okay, no problem. Thank you. Please take over the hosts.
Thank you, judges. Let us move on to our next presenter, Kiran R, with registration ID RMC Kach 0223. All the best, sir.
Is my slides visible?
Yeah, we're able to view your screen. The slides are not yet visible.
No.
Yeah, they're visible.
Good morning. My topic is next adults, its utility and acceptability compared to standard nutritional assessment techniques in screening for and obesity. This is Kiran R, intern in Apoya Medical College. There are many anthropometric techniques in screening for overweight obesity. These are body mass index, waist circumference, hip circumference, etc. These may be difficult or less acceptable in young people in community and in outpatient settings. The objectives of my study were, the present study was conducted in medical students in tertiary teaching hospital in Mangalore to assess the utility and acceptability of neck circumference as a screening tool to screen for overweight and obesity, and to compare neck circumference with other anthropometric and nutritional assessment techniques. The materials and methods. The study was done in a tertiary teaching hospital of Mangalore. Study population involved students. It was a cross-sectional type of study which was done in between July-September 2019. Quarantine sampling method was adopted. Our sample size was calculated as 282 and was based on the prevalence of overweight and obesity in NFHS 4, which was 20%. We conducted anthropometry using standard procedures. Height and weight were measured using Sika instruments to calculate the BMI. Waist, hip, and neck circumference were measured using non-stretch tape by Sika. Waist circumference greater than cm in men and 80 cm in women were considered overweight. Waist hip ratio of 0.9 in men and 3 in women were considered overweight. Body composition was measured using research grade bioimpedance analyzer. Sensitivity and specificity of neck circumference was calculated against the standard anthropometric measures and with BIA as gold standard. This table describes the prevalence of overweight and obesity using various anthropometric indices and BIA. Of the 202 participants, there were 151 female participants. Using the WHO, there were 83 participants who were overweight and 19 obese. Participants with high waist 38.7% and high waist ratio were 24%. Using bioanalyzer, the participants with high body fat percentage were 66%. Here, percentage body fat 20% or more in men and 28% or more in women considered high. Table 2 describes the sensitivity and specificity of cutoffs for circumference against BMI, waist circumference, waist hip ratio, and body fat percentage. We calculate Udan index, which is a composite index of sensitivity and specificity. The optimal area under the receiver operative curves for neck circumference. The proposed cutoffs range from 31.3 centimeter to 32.9 centimeter in women and 36.5 centimeter to 37.1 centimeter in men. With Euler index of 0.64 in men and 0.63 in women and an area under the curve of 0.82, neck circumference compared best against the BMI for overweight and obesity. Thus, as per the study, the proposed cutoffs are 36.5 centimeter in men and 32.5 centimeter in women. Neck circumference had better specificity for women with respect to body fat percentage as compared to men. Participants had BIA followed by neck circumference, almost 90% preferring BIA and 80% preferring neck circumference. BMI has its own limitations when it comes to detecting central obesity and disorders in Asians. The neck circumference stabilizes in adulthood, and any increase is indicative of deposition in the absence of any thyroid or other soft tissue disorders. It can, therefore, be an accessible and easy method of screening for overweight and obesity. While BIA is very accurate, it is available, our participants who are medical students being aware of the accuracy, hence preferred it against other methods. But this was followed by neck circumference as a preferred method. This slide describes some key international studies. The cutoffs range from 37 centimeter to 39 centimeter in men and 33 to 34.7 centimeter in women. A systematic review in 2017 that included 11 studies globally found that there is a wide variation according to ethnicity, and each country will need its own cutoffs. The best sensitivity and specificity were for adults and in women. This slide describes the studies from various parts of India, mostly in adults, except one which was done on children in Maharashtra. Sample size range from 300 to 400, and cutoffs range from 36 to 37 centimeter in males and 32 to 34 centimeter in females. To conclude, neck circumference as a tool for overweight obesity screening can be considered where there are constraints in using BIA, waist circumference, etc. BIA was the most acceptable tool, followed by neck circumference. Our study has limitations, convenient sampling, and was done in one center. Nationwide surveys with representative sample can give country-specific for the easy to perform screening measurement for overweight and obesity. That's some of my references. Thank you.
Thank you for that wonderful presentation, sir. I would like to request the judges to begin the discussion session.
Thank you. Shall I start, Dr. Arvind?
Please go ahead, Dr. Shalini.
Do you think, Kiran, would it be better to use the Asian cutoff for BMI?
Yes, ma'am, it will be better, but we wanted to compare our studies with the global studies, so we use that also. It will be better, ma'am, if we use Asian cutoffs.
Asian cutoffs? Sorry?
Ma'am?
Yeah. Why do you think Asian cutoffs would be better?
Ma'am, the BMI, the range is different for Asian people. Like it ends at 22.9.
So? Yeah.
Central abdominal fat deposition is more in the Asian people, so it would be better if you had used South Asian cutoffs.
All right. So, what is the cost of BIA? Won't it be more expensive?
Yeah, BIA is very expensive, ma'am. So that is an expensive.
Yes. So very accessible. Probably because they were all medical students and be free of cost, I'm not sure. So they might have preferred that. All right. Yes. And you have mentioned something called systematic reviews.
Yes, ma'am.
Can you explain what that is?
Ma'am, the study Crawl 20 was done in 2017, which included 9 countries. It was a systematic review of 11 studies, ma'am.
Yeah. What is a systematic review? Are you aware of it?
Ma'am,
no problem.
Review of the 11
Were there any limitations? I'm sorry. Were there any limitations in your study?
Yes, ma'am.
Oh, you mentioned that. All right.
Yes.
Yeah, you mentioned that. Thank you. Anyway, very good attempt. And I think this was a student award, isn't it?
Yes, ma'am.
Good. Thank you.
Thank you. Yeah, just a couple of things in addition to what Dr. Shalini asked. Again, I know I'm harping on this a bit, but when you use the sample size calculation formula which you have used, what is the ideal method of sampling that you would like to use with that formula?
Use convenient sampling method and
I know what you use. I'm asking you what is the ideally used method. If you
representative sample
calculate your
which you should
sample
have used.
size using that formula which you have used, which is z squared into pq by d squared, what is the ideal sampling method?
The representative sample.
Any techniques you've heard of? Okay, never mind. Now, in your objectives, can you just go to your objectives?
Yes, sir.
You wanted to assess utility and acceptability. How do you measure utility and acceptability?
The utility is basically whether we can use circumference as a screening tool to screen for overweight obesity. That is utility, sir.
I know, but how do you
Acceptability is
measure that?
basically, sir, we compared it with the BMI. So if next circumference is matching with a BMI of more than 25, so that
That's
we
your
can
second. That's your second objective, to compare it with other anthropometric assessment techniques. But my question is with your first one. When you put up a term which is like utility and acceptability,
yes,
you must have an indicator which measures that. You know, it's either measuring utility or measuring acceptability, something like that. So that's just something for you to keep in mind. Now,
okay, sir.
in your limitations or your conclusions, just go to your conclusions. One more. Yeah, conclusions. Before this, I saw a list of conclusions. Okay, just go before this. Sorry, I'm looking for a particular slide which I didn't note the number of. Just go before again, perhaps before this. Yeah, hang on. If BMI has a, no, this one, discussion, sorry. Okay, if BMI has a limitation, then
Yes, sir.
your conclusion is the neck circumference compared with BMI, correct? You have chosen
Yes.
BMI as the best comparator. But you
Yes.
yourself are saying that BMI has a limitation. How do you reconcile these two statements?
Sir, in the clinical setup, when we use BMI as a screening tool for central obesity and in detecting obesity, BMI will have limitation. So instead of that, we can use neck circumference. That is what I wanted to mean in the slide.
But your conclusion is neck circumference. You have compared the sensitivity and specificity using BMI and have come to that cutoff as being the best. Yes or no?
Yes, sir. Yes, sir.
So, if you're saying BMI has a limitation, then perhaps it's a different thing. You probably need to stick to your gold standard of BIA, though it's a costly method.
Yes.
But that's the gold standard technique, and you traditionally measure against a gold standard for checking the validity of this one. Okay, thank you. I'm done. Back to the host.
Thank you, sir. Thank you so much.
Thank you, judges, for those wonderful insights. Let us call upon the last presenter of the day, Sai Kishan Sasikumar Menon, with registration ID RMC Kach 0253. All the best, sir. Sai Kishan, sir, we're not able to hear you.
We are contacting him right now. He is not. We're not able to hear him. I think he's unmuted, but we are not able to hear him.
Oh, we wait.
Am I audible right now?
Go ahead.
Okay. So, very good morning to one and all. My name is Sai Krishnas Menon, and I'm currently studying in final year in Sri Siddhartha Medical College, Tumkur. Today, I'll be presenting my research paper on the topic Knowledge, Attitude, and Practice related to COVID-19 among medical students of a rural medical college in Tumkur. I think COVID-19 requires no special introduction, as the entire world has been discussing and deliberating about it for the last so many months. As on December 2020, the number of confirmed cases have risen to almost 7 crore, including 15.9 lakh deaths. India, who's currently at number 2 position after US, has almost 99 lakh confirmed cases with 1.5 lakh deaths. And Karnataka has about 9 lakh cases and up to 12,000 deaths till date. We all know that there are no approved treatments for COVID-19 as of now, and the only way to control its spread is by prevention, social distancing, basic hand hygiene, and the use of masks. I am a final year medical student, and I strongly believe that we students, who are the future of the medical community, must show a sense of responsibility to be well versed with the current situation. Hence, we have conducted the study to assess the knowledge, attitude, and practice related to COVID-19 among medical students from Medical College in Tumkur. The materials and methods. This cross-sectional study was conducted from August 2020 to December 2020. All the medical students from first year to final year who were willing to fill the online form were the study subjects. The data was collected in the form of a pre-tested, semi-structured questionnaire. Coming to the methodology. Firstly, the institutional ethical committee clearance was obtained from the institution. Then Google Forms, which included questions related to knowledge, attitude, and practice, was created and circulated to students through WhatsApp. All students who were willing to fill the online form were the study subjects. Data was collected using a pre-tested semi-structured questionnaire and analyzed using EpiInfo 7.0 and descriptive statistics. Also, the study subjects were ensured confidentiality. Now, presenting the results of my study. Among 540 students in our college, 408 responded to the online questionnaire. The study subjects were in the range of 22 years, with interquartile range of 21 to 23 years, and a majority of them were females. Coming to the knowledge component, all of the study subjects were found to be aware of the coronavirus. Social media was found to be the most common source of information. 99.6% knew that the first case was reported in China. 87.5% knew about the mode of spread. 70.1% knew about the prevention of COVID-19. Three-fourths of them were aware that all age groups are susceptible for COVID. 86.8% knew about the symptoms of COVID-19. More than half knew that there was no definitive treatment for COVID-19, and almost all the subjects knew that there was no vaccine for COVID-19 at the time of data collection. Now, coming to the attitude regarding COVID-19, it was found that 38% sometimes felt worried that someone that they knew may have had an infection. 63.1% were of the impression that COVID-19 is extremely serious in nature. More than half felt that the government initiatives were not adequate in preventing COVID-19. 71.1% felt that the lockdown helped in reducing cases, and more than three-fourths felt that the lockdown needed to be extended to reduce the caseload. Almost all the subjects felt that the precautions like hand washing, isolation, quarantine, and social distancing were adequate measures to reduce the transmission of the virus. Around 50% of the subjects had a positive attitude towards home quarantine of suspects and isolation of COVID cases. Majority of the subjects had a neutral attitude towards the use of masks in preventing the spread of the virus. Information on how to wear a mask correctly was looked for by 68.1% of the subjects. Coming to the practices regarding prevention of COVID-19, almost all the subjects had good practices towards COVID-19. They washed their hands with soap and water regularly, wore masks to avoid the transmission of the virus, maintained social distancing, kept track of the progress of the disease through media, and followed government guidelines and preferred staying at home during lockdown. So, in conclusion, my study showed that the subjects had good knowledge, a positive sense of attitude, and also followed effective practices against COVID-19. It is evident that there's a lot of room and scope for improvement in this organization of health awareness programs, and the effective use of social media to convey messages are some of the few ways by which each and every one of us can play a part in this ongoing battle against this virus. Before I wind up with this presentation, I'd like to thank the organizers and the judges of KachCon for giving me this wonderful opportunity. Thank you all once again.
Thank you, Sai Kishan sir. I would like to request the judges to begin the discussion.
Okay, please go.
Yeah, thanks, Dr. Shalini. Yeah, nice. I mean, I think that Shashi Kishan Menon
Sai Kishan.
presents nicely. Sai Kishan, sorry. Sai Kishan Menon, your presentation skill is good, as in you speak clearly. That's a good thing. Keep that going.
Thanks.
Now, that said, in your study, you use the term universal sampling. What do you think is the meaning of that?
Sir, what I understood was that all the students who were interested in answering the questionnaire, they took part in it, and that's what was they were included into the study.
Okay, you probably need to revisit your understanding of the term universal sampling. First of all, the term itself is an ambiguous kind of one, universal sampling. But you might want to just look into what that actually means.
Definitely, sir.
Now, yeah, so this was restricted to the medical colleges of a single medical college, correct?
Yes, sir. Yes, sir.
Okay, and I think your title reflects that. Okay, I think I don't have anything additional. Dr. Shalini, go ahead.
Yeah, thank you.
Thank you, ma'am. I'm sorry, ma'am, I'm not able to understand.
Response rate is very. Did you hear me? You didn't tell us response rate. So would it make a difference
Yes,
if
ma'am.
the response rate is low?
Yes, ma'am. Yes, ma'am.
All right. So what are the limitations of your study?
Ma'am, I'm not able to understand.
Sai Kishan, she's asking you what are the limitations of your study?
Limitations of the there were not much of a limitation. It was only the delay in the response from the students as such. Otherwise, there were not much limitations that was faced.
Back to the host, please.
Well, back to the host, please. Thank you, Sai Kishan.
Thank you, judges and all the presenters. At the end of the session, I would like to request all the participants and the judges to switch on their cameras for a quick picture.
Thank you so much. We thank all the participants for this wonderful and enlightening session, and we thank the judges for their valuable feedback and guidance. With that, again, we would like to say thank you to Dr. Arvind and Dr. Shalini ma'am for taking the time out to judge the session. So, if you have commitments, you may exit the.
Yeah, thank you, hosts. Thanks, Dr. Shalini, for calling me to this session. It was nice. Participants, keep it up. The efforts are there. God bless all of you. I'm sure that as you go on, your quality of studies will improve step by step. So, that said, thank you very much for this opportunity. Have a great day. Thank you. God bless.
Thank you, sir. Thank you, sir. Yeah. With this, we conclude the session. May all leave. Shalini, ma'am, do you have any words? Ma'am, I think.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Good afternoon, everyone. Welcome to the 32nd State Level Annual Conference of Association of Community Health hosted by Ramaya Medical College. Uh, with this, we shall begin our session 22. Let us take this opportunity to introduce our esteemed judges for today. Today, our judges are Dr. Akshay M, Associate Professor, Enupaya Medical College, Manipal; Dr. Lalita Hiremet, Professor and Head, Oxford Medical College, Bangalore. So, we are thankful for dedicating your precious time to judge this session.
Yeah, am I audible? Dr. Akshay here. Am I audible?
Yes, sir, you are audible,
Yeah,
sir. But your
okay.
video we cannot see actually. Your video is not visible.
Yeah, I don't know what's the problem with that, but that's okay. I'll try. But if my voice is visible, I mean audible, that's fine, I think.
Yes, sir,
I
yes,
wanted
sir.
to just
Absolutely
check out
fine.
that. Yeah, thanks
Yes, sir, yes.
for that. Thanks
Myself,
for that.
Priya Hulamani, 7th term MBBS, Ramaya Medical College. So let's begin our session. I want to tell some instructions before. We give 6 minutes for the presentation and 2 minutes for the question and answers. So
Hello.
let's, uh, yeah, who is that? May I know?
Hello. Are you audible?
Yes, ma'am, you're audible, ma'am.
Oh, yeah.
Yeah, ma'am.
We can start session.
Yes, ma'am, yes, ma'am. Let's start this session with the first participant, Dr. Geeta S. Ma'am, you are there, Dr. Geeta S.
Yes, ma'am. Am I audible?
Ma'am, we are making you a presenter. You can present your PPT and you have to on your video. If you are unable to switch on your videos, please do introduce yourself before presenting. Thank you.
Am I audible?
Yes, ma'am.
Shall I start the presentation?
Yes, ma'am. Yes, ma'am.
Good afternoon, everyone. My topic for presentation is e-health and telemedicine practices and beliefs among undergraduate medical students and research institute.
It's not clear.
Ma'am, your voice is disconnecting, ma'am.
Am I audible?
Can you
Am I
please
audible
be
now?
loud, ma'am? Yes, ma'am. Yes, ma'am. Now it's perfect.
The title of my presentation is e-health and telemedicine practices and beliefs among undergraduate medical students of Bangalore Medical College and Research Institute. Can be a potential tool for continuous and contact health coverage and thereby contributing to universal health coverage. The successful adaptation and integration of e-health and telemedicine concepts in clinical practice depends on the structural issues in the settings where they are being used, available infrastructure, the health needs to be addressed, and ease of use of technology itself. So, for progressive evaluation of end user needs, preferences, barriers, and benefits for the appropriate implementation of e-health and telemedicine. Conducted to assess the perceived views, benefits, and barriers regarding e-health and telemedicine among undergraduate students of Bangalore Medical College and Research Institute, and to evaluate the prevailing online health information retrieval preferences among undergraduate medical students. Clearance, a cross-sectional study was conducted at Bangalore Medical College and Research Institute from September to October 2020 among undergraduate medical students. Universal sampling technique was adopted for the study. A pre-tested semi-structured questionnaire which assessed self-reported views, barriers, and benefits in the context of e-health and telemedicine was used. Data was collected through the online platform using Google Forms and consent was through the same.
A total of 102 students participated in the study. Data was entered in MS Office Excel and analyzed using SPSS version 20.0. The mean age of the study participants was found to be 21.24 with a standard deviation of 1.46. 0.8% of the study participants and males constituted 38%. On assessing how well the participants felt about e-health and telemedicine, it was found that 42% of the participants perceived that they are moderately informed about e-health and telemedicine, 29% felt that they are less informed, and 9% felt that they are poorly informed about e-health and telemedicine concepts. The reliability of health information from internet was given a low approval. That is 45.1% of the study participants felt that the health information from internet is not reliable. The reasonability of exchange between healthcare professionals and patients, 40% moderate approval towards the same, and 34% of the study participants gave a low approval. The statement that it is useful to collect health data through portable sensors to recommend healthy lifestyle or to monitor chronic illness, both the statements were given a moderate approval by the study participants. Assessing the potential barrier benefits of telemedicine. The statement that telemedicine offers location-independent healthcare services were given the highest approval. This was followed by the statement that telemedicine reduces healthcare costs. The participants were least optimistic that data security and privacy are guaranteed for electronically collected data. The overall approval based on barriers and benefits of telemedicine found that 51% of the participants had a high approval, 41% had a moderate approval, and 28% had low approval towards the barriers and benefits of telemedicine. Health information retrieval preferences among medical students was assessed using a multiple choice question with 12 options, and upon ranking the option, the specific diseases, symptoms, and therapeutic options and meaning of specific medical terms were the most common items overall. It was followed by dosage of any drugs and side effects, prescription and non-prescription medicines. The least searched item was smoking cessation and nicotine therapy. The majority of the participants expressed that they are moderate, 42%, to less informed about e-health and telemedicine. Only 28% of the study participants agreed that telemedicine enhances quality of healthcare. The participants also opined that telemedicine offers location-independent healthcare
You have
services
1 minute
and
to
reduces
conclude your
healthcare
PPT, ma'am.
costs. Privacy and security was also raised by the participants. So to recommend, e-health and telemedicine should be an integral part of medical curriculum to increase the knowledge and awareness among healthcare professionals. These are my references. I'd like to take this opportunity to thank the Director cum Dean, Bangalore Medical College of the study. I would also like to thank the participants of my study and the faculty and postgraduates from Department of Community Medicine for their valuable inputs. Thank you.
Is there any, now topic is open for discussion. Is there any question from audience?
Madam, there are no questions as such, so you may ask or I will ask with your permission.
Yeah, you can ask. Sir.
Yeah, Dr. Geetu, it was well presented. I have some questions, especially for you. You tell that it is universal sampling, whereas Bangalore Medical College has got 750 students, and you have included 102. How can you justify this? That is the first. And second thing is you have tested some beliefs in your study. So, what study design would you like to use to test these things better? Yeah, two questions from my side.
Universal sampling. I had contacted all the students, undergraduate students, sir. We have around 1,000 undergraduate students here. 250 per batch, and I had contacted the students through online platform, that is Google Form. I had contacted all the students, and only 102 students were willing to participate in the studies.
Okay, so what is the generalizability? What is the generalizability in such a low response rate? What is the minimum expected response rate in any cross-sectional study? You got my point? Did you
Yes.
understand what I asked? Yeah. So
My response rate was only 36%, sir. So generalizability is actually less in my.
Okay. So what about how would you like to test the beliefs?
Study on the qualitative aspects, then there could have been better outcomes, sir.
Okay.
You will talk about.
Okay. Fine. Yeah. Over to ma'am. Dr. Lalita can take over.
Sir, already this time up, we can go for the next candidate.
Okay. Yeah. Thanks.
Thank you, sir.
Start with. So that was such a great presentation. Now we are moving to the next participant, Dr. Thompson Davis. So welcome, sir. You can stop your presentation, and sir, you can start sharing your
Good
screen. We are
afternoon.
going to give access to you. Delegates are getting the stopping their screens, and they can just log out and log in again.
Good afternoon, all. May I get an option to share my PowerPoint, please?
The first.
Yeah. You can't display now.
Yes, sir. We are giving access to you.
Now you can present, sir.
Excuse me, just give me 1 minute, please. I'll just share the.
Sure. You can take your time, sir. I am requesting Aniket to start their video. They didn't.
Is my slides visible, please?
Yeah, it's clear. Go ahead.
So, good afternoon, everyone. Presenting to your study term, titled as Nomophobic Behaviors Among Students in a Private College of Professional Education in Anekal Taluk, Bangalore Urban District, a mixed method study. In the study, we tried to study about a concept called as nomophobia. So it's a portmanteau of the words no mobile phone phobia. Nomophobia is defined as the irrational fear of being without the phone, being not able to use the phone for some reason such as absence of the signal or low battery. Studies show that using rise of mobile phones and nomophobia is adversely affecting the daily activities as well as the academics of students. In our study, we aim to assess the nomophobic behaviors among college-going students and to find out the associated factors. Our study was a cross-sectional study. We used both quantitative and qualitative methods. In quantitative part, we used a pre-tested self-reported structured questionnaire, which includes socio-demographic characteristics and a validated NMPQ questionnaire to assess the nomophobia. We administered the nomophobia questionnaire to 436 students. The qualitative component, we did a focus group discussion. We did focus group discussions and key informant interviews to enrich our quantitative data across all the departments in a private college. That's from computer science, mechanical, EEE, and ECE. We did a universal sampling, and we interviewed 436 students. Coming to the results, we interviewed 430 students, as we mentioned, and the mean age of the population was 19.09 plus or minus 1.272 years. About 57.6% of the students were in the male gender category. Coming to the nomophobia, 19.3% of the students fell under the severe nomophobic category, scoring more than 100 out of the NMPQ questionnaire of 140. Most of them fell under the category of moderate nomophobia, which is 61.2%. Only 0.5% of the students fell under the no nomophobia category. Even though it was a private engineering college, we are amazed to see that a lot of students didn't have their own mobile phones. So following that like we try to associate students who doesn't have their phone, and it was found significant that students who have their own phone were significantly associated with nomophobia. Those who felt that they had a lack of concentration due to overuse of phone were significantly associated with nomophobia, and this can have serious academic implications. Coming to the qualitative part of it, when we analyze the transcripts of focus group discussions and key informative interviews, we identify the following themes under the domain of health. Students believe that the phone addiction has an impact on physical health, psychological health, perceptions, and social health. According to a psychiatrist who was a key informant, the nomophobia can lead to cognitive repercussions such as inability to concentrate, stereotypical behavior, along with affective repercussions such as irritability and sleeping disorders. When students and faculties were interviewed following themes under academics, many felt that they should be focusing more about the studies and not the mobile phone. The sub-themes were information, the phones were used for information, forums, public forums, tools, storage, and for productivity. Coming to, with regard to the main domain of recreation, students were excessively using social media such as Facebook, WhatsApp, Instagram, and TikTok, multimedia for web series and movies. And a lot of students were indulged in excessive gaming and relationship in terms of social media. According to a student of focus group discussion, he mentioned that I use phone for around 8 hours. I have 2 phones. I may use it or not use it. I want to have a charged phone with me always. It should be near me always. It is not important that my family is more important. Phone is just a gadget for me. Under the domain of day-to-day activities, we found out 4 sub-themes, that is communication, trade, accounting, and emergency services. The phone addiction is very much evident from a verbatim that says, if somebody sent even just a hello, I feel like replying straight away, don't want to delay it. Sometimes I feel like replying after 2 hours or so, like let the notification come, but sometimes it is not even possible to hold myself from replying just that. In conclusion, most of the students were found to be moderately nomophobic, and even though they know the harmful effects of excessive phone use, many were incorporated to use the phone because of their day-to-day activities, recreation, as we mentioned in the focus group discussions. Recommendations, since we have found a high prevalence of nomophobia among students, we would like to encourage for the students
Only
for
1 minute
extra
left. Conclude your slides.
other extra and co-curricular activities such as sports, drama clubs, etc. Health educations regarding physical and mental health effects of excessive mobile phone usage should be done among school children, college students, and parents. Colleges should implement strict rules against usage of phones during academic hours. Here are my references. Thank you.
That was such a great presentation, sir. Now it's
Thank
time
you.
for Judge. Judge, you can start asking the question and answer.
Hello. Hello, Akshay sir, can I ask question?
Yes, yes, please. Please, ma'am.
Thompson, it is really good study. You have
Thank you,
conducted
ma'am.
study, it's need of hour. And
Thank you, ma'am.
generalize your observation and
Yes,
which
ma'am.
is the best sampling method for your study?
Sorry, ma'am.
To generalize your observation to the
Yeah.
community
Yes, ma'am.
and which sample size method you can take.
Simple random sampling. Since we had a list of students from the college, we could have used simple random sampling, but since we did a universal sampling, the number of students were really high. It's around 556. So we couldn't use a simple random sampling, so we used universal sampling.
Okay. What were the objectives of your qualitative part? So, what is this qualitative part? Can you highlight upon the analysis what you have done, how you have done this?
So we did a inductive analysis. So basically, since it's a new word called as nomophobia, not many students were familiar about the word nomophobia. So we thought we'll ask about what were the reasons why they were in a probable cause of getting addicted towards phones. So our topic guide consisted of questions like, were you able to sleep if you don't have a phone with you, or do you feel like seeing the phone, checking the phone even though you don't have a notification on it? And even to the key informants, that's the faculties and the HOD of the departments, we asked them how distracted are the students if they're allowed to use the phone in between the classes, and will that have a serious implication on the academic part? And to the psychiatrist, we were asking about the technical and the symptomatic prevalence of nomophobia among the students, among the patients which he saw in his OPD.
Okay, okay. One more question.
Sure,
How did you select these participants, especially in the qualitative part?
So since it was we was trying to get the focus group discussions, we tried to get each a representative from each department. So we have studied across 4 departments as computer science, mechanical, EEE, and ECE. So we tried to get a group of 2 or 3 from each groups to understand various problems they face in between the academic hours, like, for the need of phone.
Okay, what type of mixed method study was this?
A quantitative and qualitative part, sir.
No, correct. Whether in the qualitative part, whether it was explanatory, exploratory, or concurrent, what is the type of?
In an exploratory study, sir.
Okay. Based on the things what I see, I look
Yes, sir.
it more towards an explanatory design.
Yes, sir.
Why were the reasons you have you try to explain based on your the quanti part? Fine, that's it from me. Yeah, thanks.
Thank you, sir.
Great presentation, sir. So now, thank you. Now we are moving to the next delegate, Dr. Abdul Aziz KK. And I am requesting to Dr. Thompson, can you please stop sharing your?
I think I've done it, ma'am.
Thank you, sir.
Abdul sir, you can share your PPT now. Yeah, thank you, sir.
Thank you, sir.
Actually,
Yes, ma'am. You were saying something?
Yeah, directly.
am I audible?
Yeah, it's not audible.
Am I audible, ma'am?
Yeah.
Yes, ma'am. You're audible, ma'am.
Okay, let me introduce myself. I'm Naisha Bilizis, PG scholar from Kottakkal Ayurveda College under the guidance of Dr. Anupama Krishnan, Associate Professor, Sustarita Department. My topic of study is telemedicine usage among Ayurvedic physicians, a current scenario. Coming to the introduction, over the past 12 months, the world witnessing historic and dramatic development related to the emergence of a virus. Likewise, any other challenges, COVID-19 comes with its own unique opportunities and innovative solutions. Telemedicine, which means healing from a distance, is an effective, affordable, and attractive option. It's an important application across entire healthcare delivery and a critical need among medical population and patients. In this scenario, it is important to assess the extent of telemedicine practice among Ayurveda physicians, the community which I belong to. Aim of the study was to assess the state of art of telemedicine practice among Ayurvedic physicians of Kerala. An objective was to assess knowledge, attitude, and practice of telemedicine among the physicians of Kerala. Coming to the methodology used was a cross-sectional study. As there was no questionnaire available in a particular field, questionnaire was developed based on an in-depth interview among Ayurvedic physicians from each specialties. Face validity and content validity was just checked. It was underwent cognitive reasoning and treat testing. The questionnaire was distributed randomly among Ayurveda doctors through online platform Google Form. The survey was run between November and December 2020, response collection on December 13, and got a very low response rate of 36%. Data was served to Excel file, collected, responses collected, and analyzed. From the responses, Actually, I confess this is just a preliminary data presentation because the research as we got a very low response rate, we are planning to extend the research, the period, and to do statistical analysis later. Now the result got was nearly half of them are practicing telemedicine, and from the other part, from not practicing, the 60% were thinking to start, and next lack of some are not practicing because of lack of technical skill, and some never felt as a need, and other is not a good option, and 0.3% doesn't use telemedicine as they can't examine the patients. From this, it was assessed that 6% has a negative attitude towards telemedicine practice. To the benefits of telemedicine practice, it was expressed as 52.3% expressed the benefit as for consultation of far of patients, 22.7% for avoiding unnecessary exposure, 11.4% for expanding the patient circle, and 11.4% for as a need in future and for an easy follow. Even though many are practicing telemedicine, it was important to know that more than half haven't gone through the guidelines issued by Ministry of Health and Family Welfare. Coming to the challenges of practice, majority of them expressed the challenge as difficult to do the treatment procedure, difficulty dispensing medicine, network issues as another disruption, discontinuation in the consultation due to bad network issues, difficulty in emergency management, and difficulty in clinical examination as the major challenges in practice. From the study, it was assessed the suggestion as the need of the customized app for Ayurveda is need of hour for the practicing telemedicine by many practitioners. Advancement in the technology and our medicine dispensing facilities, etc., were mentioned as the suggestions for bettering the telemedicine practice. And other suggestions were proper documentation facilities and by assessing the duration of commencement of telemedicine practice among the practitioners, it is evident that the pandemic has surged the usage of telemedicine. Even though nearly half of the respondents are practicing, they are not acquainted with the guidelines regarding professional contents and ethics issued by Ministry of Health and Family Welfare. Customized apps for the street was the suggestion from the study. Even though nearly half of the telemedicine practitioners, even though telemedicine has its potential to be present in the healthcare breaches, it should be needed to be popularized more among medical fraternity and medical patient population. To the conclusion, it is said that telemedicine cannot be an answer to the odd, but it can be a substantial contribution to cope up with the current pandemic of COVID-19. Continuous training programs are required, which it can help to decrease the burden of healthcare system and to prepare better for any future pandemics. These are my references. I would like to thank all the practitioners who took part in the survey. Thank you.
Thank you, ma'am. That was such a wonderful presentation. I request judges to initiate the discussion.
Yes, it was a good presentation, Naishu. I just want to get some replies from you as far as how did you select these practitioners and whether they were belonging to all parts of Kerala? Because you tell that it is a study done across Kerala, but only 90 odd practitioners were a part of your study. So how is this possible? So can you just shed light upon how did you look into the sampling?
Thank you, sir. Actually, I'm also worried about the sampling now, as I heard, I selected it by a simple random sampling to the accessible doctors. I randomly forwarded the questionnaire to accessible doctors, but I think this is not the right way as I have seen the previous presentations. So I would like to correct sampling methods.
Hello, Naishu.
Okay.
Hello, ma'am.
To select the random sample, you need to have the total number of the participant in the beginning only. No? How you selected randomly?
Ma'am, as I already said, I was randomly forwarding the questionnaire to the doctors which I know. I think there is a problem with sampling. I will
Then
definitely go to
what is your study methodology?
So
You selected the
cross-section
participant randomly. Then what is the methodology you used for the to conduct the study?
I opted cross-sectional study, ma'am.
Do you think is it correct?
Ma'am, I need your suggestion, ma'am.
What type of methodology you used in the cross-sectional studies? Selection criteria?
As this is a kind of survey study, I thought this was the method to be used.
At least you need to have the complete list of the doctors, those who are practicing in Kerala.
Okay.
And
Thank you, ma'am.
that is a huge task. So that is a huge task. You can do this particular study only in your place where you are practicing,
Yeah.
and then
As sir told, it is best you select the small area, geographic area.
yeah. And whatever you have done, it is a convenient sampling. There is no other sampling which is there over here. I think you have
Yes.
sent the questionnaire to all the people who were there in your mailbox. So that is what you have done as far as the study goes. Fine. And in the last slide, you have put up that this is helpful in preparing for future pandemics. I am not really convinced about that because your conclusion should be based upon what has come out from your study. And I think you need to look into that. Yeah, that's it from my side. Yeah, thanks.
Yeah, as already sir told, you took the purposive sampling. With the purposive sampling, we cannot give the conclusion and generalize the whole thing for the whole population.
Okay, so okay, ma'am. Thank you for your valuable suggestions. I will definitely look into it. Thank you, ma'am.
Thank you, Dr. Nish ma'am. Now we are going to the next participant, Dr. Arpita VS.
Ma'am, we have already made you a presenter. Can you please share your PPT, ma'am? Arpita.
Yeah.
Yes, ma'am.
Are my slides visible?
Yes,
Yes,
ma'am.
ma'am.
Please.
Shall I start?
Yes, ma'am.
Good afternoon, judges and everyone. Myself, Dr. Arpita, and I'm a postgraduate from STM Medical College, Dharwad. And my study is on mid-upper arm circumference as a feasible tool to assess the nutritional status among adults.
Madam, can you just put it on slideshow? Yeah,
Yes,
thanks.
yes.
Thanks.
Malnutrition can be undernutrition, overnutrition, and micronutrient-related deficiencies. Globally, 1.9 billion adults are overweight or obese, while 462 million are underweight. According to NFHS 4, underweight is 19.6% among males and 22.4% among females. There are many methods to assess the nutritional status. One is BMI. Height and weight of an individual might be difficult for non-ambulatory persons and also in low resource setting. So, can mid-upper arm circumference could be a feasible and easy method to deploy in community settings. We conducted a study with the objective to assess the feasibility of mid-upper arm circumference to measure the malnutrition status among adults attending the Rural Health Training Center, STM Dharwad. This was a cross-sectional study which was conducted for a duration of 1 month, that is August 2020, which was we included the participants, adults aged between 18 to 60 years of age. And those pregnant and not willing to participate were excluded from our study. The data entry analysis was done using Microsoft Excel and SPSS version 23.
The descriptive statistics like percentage and frequencies were calculated. The mean and standard deviation was calculated for metric variables. The mid-upper arm circumference cutoff for the BMI values was determined using the receiver operating characteristic curve. A total of 66 subjects participated. Majority of the participants were belonging to the age group of 21 to 30 years of age. The mean age of the participants were 38.5 years in case of male, and in case of females it was 41 years. And 51% of them were females, 37.8% were farmers, 93 belonged to Hindu religion, 24 were illiterate, and 45 belonged to class 4 socioeconomic status. The table 1 showing the proportion of malnutrition according to the BMI status. 9% of the study participants were underweight with a BMI of less than 18.5, and 57.6%. Majority belong to the normal BMI value, and the rest were of overweight and above. The table 2 showing the anthropometric characteristics with respect to gender. The mean height of the participants were 169 centimeters in case of male and 155 centimeters in case of female. The weight was 67 kg in case of male and 56 was in case of female. The mean mid-upper arm circumference was 27 centimeters and 26 centimeters in case of male and female respectively. The table 3 showing 2 into 2 cross-sectional table for undernourished and normal individuals with respect to mid-upper arm circumference and body mass index. And here we excluded 22 of them because they were overweight. And the sensitivity and specificity for this table was found to be 50% and 92% respectively. And the table 4 showing the area under the curve and mid-upper arm circumference cutoff value based on the body mass index. With the body mass index of 29.9 value, we found a cutoff of 29.5 centimeters, area under the curve of 0.892, and it was statistically found to be significant. The sensitivity and specificity for this was 83 and 80% respectively. We also found mid-upper circumference cutoff for the BMI of 25.9 and 18.5, but was not found to be statistically significant. Hence, I conclude my study saying mid-upper arm circumference can be used as a feasible tool to assess adult malnutrition in a resource-poor setting, and a cutoff value of 29.5 centimeters can be used for BMI of 29.9 and above as an alternative to measure the adult malnutrition, that is overnutrition. And these are my answers. Thank you.
Now I request judges to initiate their discussion. 2 minutes time is given for discussion.
Hello.
Hello.
Hello, Arpita.
Yes, ma'am.
Anyhow, you are discussing about the mid-arm circumference as a tool to assess the malnutrition, and you are comparing with the BMI also. Which is the best methodology to give your conclusion?
Ma'am, I am taking a BMI as a standard, and I wanted to see how mid-upper arm circumference, when compared to BMI, can assess the nutritional status.
And how you selected the sample size?
Ma'am, my sampling was a convenient sampling, ma'am. Those patients who were attending the RHTC were selected.
It is better to take the community-based study.
Yes, ma'am. It is better to take a community-based
hospital-based study and that to purposes sampling.
Yes, ma'am.
Difficult to generalize the things.
Yes, ma'am. This was a pilot study, ma'am. We wanted to continue this study for the larger scale. Then we go for a community-based study.
Yeah, of course, it is a good study. If it is a pilot study, it's okay, no problem.
Thank you.
Arpita, that's a very nice topic, but you can improvise upon the study design as well as the sample size. Okay,
Yes,
I am not clear about you are telling the feasibility. So you have checked for the sensitivity and specificity of a new tool or an existing tool with the gold standard, correct? So what does feasibility include other than this? because you have brought in that particular word. So feasibility will also include so many other things. So do you know what it can include?
So the ease of measurement.
Correct. So where have you measured that? Where have you assessed that?
So that I have not assessed because we have done it in RHTC, sir, because all
Correct,
were
madam.
training doctors. So yes, sir. Maybe
Correct.
that word I should have not used.
So you have to that is not the right word to use in the title when you are you want to compare MUAC versus BMI, right? So that's
Yes.
what is your objective, and you are
Yes, sir.
not
Yes, sir.
looking into how good this particular thing is. This thing is as far as the feasibility from the user perspective as well as the acceptability from the end user
Yes, sir.
perspective. So you have not looked into that. So that particular word doesn't fit in as far as this particular title is concerned. Otherwise,
Yes,
it's
sir.
a good study. You may have to look into this particular study with a larger perspective and a bigger sample size. And I think it should go for a community based rather than hospital
Yes, sir.
based.
Yes, sir. Sure,
Okay.
sir. We'll
Yeah.
continue in the further next steps, sir. Thank you for your suggestion, sir.
Yeah. Thanks.
Thank you, sir. Now I request judges to initiate the discussion.
Do we have any questions, ma'am? Or shall we move to the next participant?
Yeah, I can.
Please go ahead.
Please go ahead.
Yeah, ma'am. Thank you, ma'am. Thank you. Next participant is Nishita, ma'am. Ma'am, kindly give us a 1 minute. We'll make you as a presenter. You can present, ma'am. You are a presenter right now.
Am I audible now?
Yes, ma'am.
All right. Okay, I'll start with the presentation. Good afternoon, everyone. I am Dr. Nishtha Malhotra from JNMC Medical College, Belgavi. The title for my study is Prevalence among elderly residing in the rural field practice area of Belgavi district, a cross-sectional study. Now, beginning with the introduction, according to WHO, elder abuse is defined as a single or repeated act or lack of appropriate action within any relationship where there is an expectation of trust which causes harm or distress to an older person. According to the WHO analysis, the most common types of elder abuse are financial abuse and psychological abuse, followed by neglect and physical abuse. Sexual abuse is not so common. According to Indian Population Census 2011, it has been observed that there is an increase in the proportion of elderly population, increase in life expectancy at birth, increase in the old age dependency ratio, and also the elderly females, they outnumber the elderly males. Now, this can give rise to a situation known as grey tsunami, in which the retired elderly population becomes more and more dependent on the working class young adults. Now, usually this dependency is perceived as burden by the elders, and this isolates the elderly, and there is a lack of affection and care towards them. They are not included in the decision making, and this can lead to loneliness and depression among them. Hence, our country should be prepared to face this issue in the coming future. The objective was for this study was to find the prevalence of elder abuse. In material methods, this is a cross-sectional type of study. It was conducted on 200 participants selected by systematic random sampling, and it was done on elderly population aged more than or equal to 60 years residing for at least 1 year in the rural field practice area of PHC Vanpuri in Belgavi district. It was conducted from 1st October 2020 to 30th November 2020. The questionnaire for this study comprised of three parts. First part was the mini cognitive test. which was to assess the eligibility of the elderly in the study. Second part was to assess the socio-demographic characteristics of the participants. And the third part was the standardized questionnaire, modified geriatric mistreatment scale, which assessed the prevalence as well as the different frequencies of the individual elder abuse type. Now, for collecting the data, house-to-house visits were conducted, and after explaining the participants about the study and attaining their informed consent, they were recruited in the study and they were interviewed. Now, coming to the results, the mean age for the participants in the study was found to be 70 years. The elder abuse was found among 28 participants out of 200, that is 14%. This graph shows us the individual prevalence of the various elder abuse types, in which we can see that out of 28 participants, 24 of the participants faced psychological abuse, followed by neglect in 14 individuals, then economical abuse in 11 individuals, and finally physical abuse in 7 individuals. Sexual abuse was not found in any individual. This table shows us the association of social demographic factors with the types of elder abuse. We can see that all the 4 kinds, that is physical abuse, psychological abuse, neglect and economical abuse, they were found to be maximum in the age group of 60 to 69 years. But also neglect and economical abuse was found to be in the same number of individuals in the 70 to 79 years of age. Females and widowed elderly were found to be experiencing more abuse compared to males or married individuals respectively. If you look at the religion, Hindus, elderly belonging to the Hindu religion were found to be experiencing more abuse, but this could be because a maximum number of the participants in my study, they belong to Hinduism. Now, if you look at the categories, elderly belonging to the ST categories faced more abuse compared to other categories, but here again, physical abuse and neglect were found to be were found in equal number of participants in the general category as well. Then elderly who were living in a joint family setup or elderly who were living with their family members were found to be experiencing more abuse compared to elderly who were living in a nuclear family or who were living alone or with a spouse or a relative. If you look at the educational status, illiterate elderly population was found to be experiencing more abuse. In the occupation, unemployed and retired elderly were facing more abuse in neglect, economical, and the psychological abuse, whereas physical abuse was found more in the laborers. Now, elderly who were owning their own house were found to be experiencing more abuse. This points us to a hypothesis that maybe because their own family members were forcing them to give away the ownership of the house. If you look at the monthly income, elderly who were not earning any income, they were found to be experiencing more abuse, but also psychological abuse was found to be in equal number of participants in elderly
You
who
have
were
1
having.
minute left to conclude your presentation.
Yes. People belonging to class by socioeconomic status were experiencing more abuse. I'll conclude the study by saying that elder abuse is prevalent in our community, in our society. Prevalence in my study was found to be 14%, and maximum was the psychological abuse and neglect. Abuse was found to be more in elderly of the age group 60 to 69 years, females, widowed elderly, who were illiterate, people belonging to class 5 socioeconomic status, who were unemployed, retired, owning their own house, or living with family. Now, the strengths of my study are that very few studies have been conducted till now. So this study highlights the issue of elder abuse. But I also have certain limitations in this study. That is, the sample size is small. Response bias could have been there because people try to maintain the confidentiality of their family matters. And it was a cross-sectional study. It was not a qualitative study. There are certain recommendations also which I would like to suggest, that certain policies and strategies can be made by the government so as to improve the reporting system of elder abuse. We can create awareness among the elderly about the redressal mechanisms, and also we can sensitize young adults towards this issue, and this will help the elderly in the future. These are my references. Thank you.
Hello, Nishita.
Yes, ma'am.
Your main objective is to study the prevalence, no?
Yes, ma'am. Yes, ma'am.
Your objective.
Yes, ma'am.
Yeah, of course, it is a community-based study, we can accept it. But mainly your aim is to study the prevalence, means you need to give the most important methodology for the study, sample size.
Yes, ma'am.
Ah.
Ma'am, I have,
Calculated the sample size.
pardon, ma'am.
How you calculated sample size? It came around 200.
Yes, ma'am. Yes, ma'am. Ma'am, actually, this is a part of my ongoing dissertation. So I had taken the prevalence from a study conducted by HelpAge India organization, that which was found to be 35%. On the basis of that, my sample size had come 400, but for this study, I have just taken 200 because till now I had completed only these many.
Fine.
Yes, ma'am.
Okay. Would you like to add any qualitative component over here? You were mentioning about that. So
Yes, sir. Yes, sir.
is it a part of your study?
No, sir, I did not include any qualitative part, but definitely, if focus group discussions are conducted or more in-depth interviews are conducted with the elderly population, then we can definitely get into the crux of the situation, and it will definitely help us in creating more awareness and getting better solutions so that elderly don't face any abuse.
Okay. Fine. Thanks.
Okay, sir. Thank you.
Go to the next presenter, Dr. KMD Shoaib. Will make your presenter 1 minute. Sir. Yes, sir. You are a presenter. You can present, sir. Sir, you are not audible, sir.
Yes. Are my slides visible?
No, sir, not yet.
I think, Dr. Shoaib, your bandwidth is very low. So maybe that is the reason we are not able to access your presentation. So I request the host to show him the presentation and he
Yes,
can
sir.
present.
Yes, sir. 1 minute, sir.
Hello. Am I audible now?
Yeah, you are
You are
audible,
audible,
Shoaib.
sir.
Okay.
Sir,
Are
1
my
minute, sir. We
slides
are.
visible?
Yes, sir. No, sir, not yet. Yes, sir.
Yeah, it's clear.
Visible now?
Yes.
Yes.
Okay.
Yes, please go ahead, Shoaib.
Yes, sir. Good afternoon, everyone. I'm Dr. KMD Shoaib from Department of Community Medicine, Bangalore Medical College and Research Institute. The title of my study is Assessment of Experience with Attending Online Classes held during COVID-19 pandemic among medical undergraduate cross-sectional study. Coming to the introduction, with COVID-19 pandemic, many of the things were affected. Among that was the classroom education, and it was almost impossible to continue as in the same method, as it was never most of the classrooms were never designed keeping in mind about the social distancing. So the immediate response from all the educational institutes was to shift the classroom academics to online mode, like the meeting which we are having right now. So there are many studies which suggest that online meetings or online education can have challenges. So we can also see a recent trend among the NEET PG aspirants to completely opt for online preparation of classes where the teachers record their videos And the same in UG students was still a distant dream. But due to this pandemic, even that was turned into a reality. So the objective of my study is to assess the availability of required infrastructure and impact of these online classes on mental and physical health. So materials and methods. The study area was Bangalore Medical College and Research Institute. Study population included the students who attended online classes for more than 1 month. And the study period was from 10th of November 2020 to 10th of December 2020. Sampling method was universal sampling data collection. And the data collection was done using a face-validated semi-structured questionnaire, which was administered by interview method using online survey using the website surveymonkey.com. And the statistical analysis was done using SPSS version 20. So details regarding the study are the online survey was sent to the students who are currently enrolled in MBBS in BMCRI. So considering the 250 intake of yearly students, so out of 1,000 students, 587 students responded completely. Around 100 gave partial responses. I mean, the survey was completed partially and rest did not consent to participate. So from the data collected, the average number of hours spent per day attending online classes was 2 to 4, and the number of subjects for which classes were conducted was 3 to 5, and the average number of months for which online classes were conducted was 3 to 8. Coming to the results, the socio-demographic results, among the participants, 61% of them were males, which comes to where N comes to 359. The age, majority of them belonged to the age group of 18 to 20 years, which were 311 in number. And 31% were 31% of the respondents were from first year, and 21% from the second year, and 29% from third year, and rest of them were from final years. So results regarding the availability of infrastructure. So 83.6% of the students, which comes to 506 number, they depend upon the mobile data for attending the online classes. And 88.6%, which comes to 520 respondents, they depend upon the mobile for attending the online. And 85% of the students, which is around 499 in number, they do not share the device with any of their family members or the friends. So 50.7% they do believe that home is not a suitable place for attending classes, and the most common reasons for 81% believe, and 56.2% face distractions, 30.2% face disturbance by family members, and 21.67% face other works which they need to do, which is given by the family members. So result regarding its impact on mental health and physical health. Coming to the mental health, the Pearson correlation between the duration of online classes per day and the impact on
Only 1 minute left.
3, and the p-value was 0.043, which was statistically significant. Top contributing factors were missing interaction with batchmates of in-person class, worry that they might miss the class due to external factors which is beyond their control, and they feel frustration and lack of interest in learning online via online classes. Regarding the impact on physical health, the Pearson correlation coefficient was 0.124, and it was statistically significant. With online classes, their average screen viewing duration has been increased. They feel headache and eye strain, and they also feel the symptoms of bad posture, which is backache. So conclusions and recommendations. So certainly infrastructure is inadequate because they depend upon mobile phones and data connections. And these online classes are having a negative impact on physical and mental health. Coming to recommendations, college can play a vital role in limiting maximum number of classes per day, and online classes can be recorded and can be made available for fixed duration, and it can be made interactive by utilizing in-app features. And adequate gap can be maintained between continuous classes. You.
Thank you, sir. Now I request judges to initiate their discussion.
Yeah, Shoaib, was a good study. I would
Thank you,
like
sir.
to I would like to appreciate that at least you have got around 80 60%, nearing 60% of the
Yes, sir.
responses. So what was the platform did you use for sending them the questionnaire?
So I designed my survey in surveymonkey.com, and I have sent the shared WhatsApp. I here chain of contact. What
Okay.
students who are staying at and attending online classes.
Okay, you have elicited some responses as far as the issues concerned with online classes. So, were those responses given by you, or was that an open-ended question? Because there was one response which is surprising, which says that the work given by the family members came in the way of their learning. So
yes, sir.
that is one. Let me tell one more. You
Yeah.
have seen the mental and physical status of the individuals and their association. So how did you gauge this? How did you look into this?
So regarding your first question, that was an open-ended question, sir, because I was not expecting that response, but turned out that response also had a good percentage. Regarding this physical and mental health, I asked them a set of questionnaire and graded them on a 5-point Likert scale. Then taken the addition of the score for the set of 5 questions, which was face validated, and correlated with the duration of the classes taken per day.
Hello.
Okay, thanks. Thanks. Yeah.
Yes. Yes.
Hello, Soeb.
Yes, ma'am.
It's really good study. And whatever
Thank
the
you, ma'am.
observations you have made in your study, it is only in favor of students. If you
Yes,
had
ma'am.
more objectives, the challenges which are faced by the faculty also.
Yes,
Hello.
ma'am. I wanted to do that study as well, but I was unsure about the rest.
Yeah, that's what even teachers also face a lot of challenges for conducting online class. What is your opinion?
Not, ma'am, because yes, ma'am, because I was involved in helping the faculty, so I wanted to conduct that study as well, but I was unrestricted. Yes.
Thanks, everyone. Thank you to the judges for giving their precious time, valuable feedback and guidelines. And thank you all the delegates and all everyone. Now we are going to end session 22 and we will start another session 25 in another 5 minutes.
Thank you.
Thank you, everyone.
Thank you.
Thank you, ma'am.
Nandikishore? ये थोड़ा टाइप करके एक मेल फॉरवर्ड कर रहे थे पॉइंट वो मेल फॉरवर्ड कर दे उसको मेल कर दे ये है ना कैच कैन 2020 I already forwarded it. Yeah, entry करो सब marks total भी करो and then you submit it to the if possible otherwise you take my signature scan सज्जन स्कैन करके भेज सकते क्या ऑनलाइन फिल करके भेजते ऑनलाइन फिल करके भेज you want not this one सज्जन right
Good afternoon. These are the moderators on the assignment. 0096 Anupriya Kushwaha. Batch ID is please unmute. Batch ID is batch today I
This is Dr. Dipti and Dr. Chetna. Ma'am, are you able to hear us?
Yeah, I can hear you.
Yeah, I can also hear you.
Okay, ma'am. Thank you, ma'am. So can we just wait for a few minutes till the participants join, ma'am?
Didn't hear you what?
No, ma'am, can we wait for about 3 more minutes till all the participants join?
That's fine with me.
Okay. Thank you, ma'am.
Yeah. Catch ID
'Catch
Kindly unmute yourself and respond.
Hello. Hello.
Yashika, ma'am, if you can hear us, please respond. We need to start this
Yes, I
session shortly. Okay.
can. Yeah.
Yeah, then we can hear you now.
Okay.
Daphne, can you hear us?
Yeah, I can hear you.
Okay, ma'am. We'll start the session for today. Good afternoon, everyone. Welcome to the 32nd State Level Annual Conference of Karnataka Association of Community Health, hosted by Ramaya Medical College. The theme for this year is Redefining Public Health, COVID-19 and Beyond. With this, we shall begin our session with Our session for today is UG oral presentations. Let us take this opportunity to introduce our esteemed judges for the day. Dr. Deepti Shanbag, Associate Professor of Community Medicine in the St. John's Medical College, Bangalore. Welcome, ma'am. Dr. Chetna T, who is the Manager in Cancer Screening of Indian Cancer Society, Bangalore. Welcome to you, ma'am. We are thankful to both of you for dedicating your precious time and being here today. Today's session will be moderated by myself, Aparna.
And I'm Deepti. We are UG students at Ramaya Medical College studying in third year.
So let's go through the instructions for the day. Okay, so pay attention, participants. You'll be given 6 minutes for your presentation, and judges will be given 2 minutes to question the participants. And participants, please stick to your time. You'll be intimated at 5 minutes when you have 1 minute left. So with this, let's start the session for today. Our first participant, Anupriya, may join shortly. So we're gonna go with Daphne. Catch ID 0100. Daphne John, are you ready?
Yeah, I'm ready.
Okay. Would you like to
Yeah,
Daphne, can you switch on your video?
yeah. Okay. Is it okay now?
Yes. Would you like to share your own screen or should we share your presentation?
I'm sorry, can you repeat?
Would you like to share your screen and share the presentation?
Yeah.
Oh.
I would like to share my screen.
Okay, let us just give you control. 1 second.
Okay.
Yeah, we have made you present. Now you can share your screen.
Okay. Okay, can you see my screen?
Not yet.
Now?
No, still
No. Just 1 minute.
if you're made us
Can you see? Okay, if it's not coming, then you can share my presentation.
Yeah. Is the screen visible now? Your presentation?
Yeah, it's visible.
Yeah, your time starts.
Okay. So let us start with the case scenario. A 55-year-old farmer, a known case of diabetes and hypertension, presents with fatigability, blurred vision, and giddiness. So he is probably one of the 69 million who's affected by a major killer of the world. So what can be the most convenient and effective form of management for this patient amidst the pandemic? This is where telemedicine comes into play, whose massive growth has brought about healthcare services under our fingertips. So good afternoon. I'm Daphne John from Government Tirvarur Medical College, and I'm going to present on the impact of e-health services amidst COVID-19, a comparative analysis between a developed and a developing country. Next slide. Yeah, next slide. Okay. So the objectives are participation of people through a virtual interface, to determine the current usage and awareness of e-health services, and to assess the areas of improvement. Next slide. Yeah. Okay. So it's a cross-sectional study which is done using an online pre-designed and pre-tested questionnaire. So the study sample size is around 100 from the general population, 50 from India and 50 from Kuwait, and the duration of study was for 1 month. It was a convenient type of sampling done, and the study tool used was an online questionnaire based on Google Forms. Next slide. The inclusion criteria of the study are participants with internet facilities, literate individuals, individuals with sound mind, and residents of India and Kuwait. Exclusion criteria are participants below 18 years of age and literate participants. So data obtained from a semi-closed questionnaire was plotted in MS Excel, and then EPI info software analysis was done. Next slide. Next, yeah. So to assess the participation of people, a few questions were asked, like what would be their first approach towards cold and flu? And around 70% of population resorted to home remedies like herbal formulations or steam inhalation, salt water gargling, or even over-the-counter medication. Next slide. So what if the symptoms didn't subside for 2 days? How would they approach a healthcare setup? We can see in Kuwait that most of the people go to a private clinic. This is because they have a higher standard of living over there. It's a tax-free country, and health insurance is mandatory. Whereas in India, what we do is we resort to consult a doctor online, either through social media or other platforms, because it can be used as a primary mode of intervention. Next slide. Okay, in case the doctor orders an investigation for a COVID test to be done, only 30% of the people in India are willing for the sample to be collected at home. Whereas in Kuwait, we can see that 72% of people are preferring medications to be delivered at their doorstep with no contact delivery. But we can see in both countries that less than 40% of the people update their health status online. Next slide. It is shocking to know that even though 64% of Indians are aware about telemedicine in my sample population, only 10% resort to its use. It's because they have a stigma that the communication skills won't be as effective as it is in person. Whereas in Kuwait, only 50% of my sample population is aware, and yet half of them are using telemedicine as a main source of communication. This is because we have better and higher internet facilities and higher dependency on technology. Next slide. Now coming to the main focus. Has COVID caused any impact on telemedicine? Over half of the Indian population are not aware about the harmful risks of COVID. They are okay with directly approaching the hospital as a first line measure. But whereas in Kuwait, we can see that the dependency on telemedicine has increased drastically during this COVID crisis period. Okay. So among the people who have used telemedicine, they have stated that the main advantages are easy accessibility and availability of the doctors online 24/7. Then there is it is highly effective for old and disabled people, and it also avoids unnecessary contacts during the pandemic. Whereas in India, they see that drug delivery at the doorstep is the major advantage. Next slide. Next slide. Yeah. Whereas the people who do not resort in using telemedicine, we can see that the main reason is because they feel that the communication skills, it won't be as effective as it is in person, and it is impossible for a doctor to diagnose online. Hence, they use alternate methods such as Ayurvedic or Siddha treatment over allopathy, and even private healthcare centers. Next slide. Next slide. Hello? Hello? Okay, areas of improvement. So how do we improve telemedicine? We can see that in India, 65% of the population is rural. Hence, we need to the government should promote e-healthcare schemes. Whereas in Kuwait, you have a well-established. Sorry. Hello. Oh, okay. I'm sorry. I couldn't hear. Okay, can I continue or should I
the
stop?
judges.
Yeah, you start.
What are your judges for questions?
Okay.
Ma'am, you're not.
Dr. Deepthi, will you go first?
Yeah, shall I ask?
Sure, ma'am.
Yeah. Okay.
Yeah.
Okay. It's a very different study, I do agree. Now, I got a query, which is this 50 people you take. Yeah, where are
Sorry, ma'am. Can you repeat again?
the 50 study population? Where are they from?
Ma'am, your voice is muffled, ma'am. Like.
Can you hear me?
Yeah. Now I can hear you.
Yes, ma'am.
Where are the 50 people you taken from?
The 50 people are from Kuwait and from India, respectively. I have divided 100 into 50.
Million population. So you have to tell me from where you selected the 50 people.
Yeah, I have taken them from the people who are residing in Kuwait, ma'am.
From India, my dear Daphne.
From India, yeah, from India, I have taken from different states, ma'am, like North India and South India. I haven't covered Northeast India, but other than that, I have covered every state, ma'am.
It is you've not shown that in results. And how did you select these 50 people?
It was by convenient sampling, ma'am.
Like I mean, how did you do a convenient sample of India?
Yeah, no. I have contacts in each state, so I have equally distributed it among them, ma'am.
You have to tell me the socio-demographic details of these 50 people whom you selected. Are they from rural? Are they from urban? What is the gender distribution, socioeconomic status? Are they comparable to the group in Kuwait?
The people from India, they were not much from the working sector compared to the ones in Kuwait, ma'am. They were, but both the population were urban population, ma'am.
Right. So when you do a comparative study, you require to have your comparable. So if you have taken high socioeconomic status in Kuwait, we expect the same similar population you select from India also, right?
Yeah, yes, ma'am.
So that's one. Then Chetna, you want to ask?
Yeah. Daphne, did you understand why madam said that it is not proper?
Yeah, because the criteria and parameters will vary if we select two different population from with two different states. Like the
50 is
population should
not,
be comparable.
yeah, 50 is not representative of India, and you have done a convenient sampling also. Did you take a ethical clearance for this?
No, ma'am, I didn't take any ethical clearance.
Okay. What do you think is how do you know that a person is of sound mind? You have said that inclusion criteria, the person should be of sound mind. How did you find out that?
Because I have personally given these forms to the people, so I know that they are of sound mind, ma'am. Distributed these forms by convenience.
That wouldn't be proper, Daphne. See, when you use some inclusion criteria and exclusion criteria, you should have a proper definition for it. Just because you assessed and you felt it is a sound mind, it can't be. Okay? Don't use such thing. And you are not supposed to do any research as such without an institutional ethical clearance.
Okay, ma'am. No, ma'am, due to time constraints and I was away, I had to do it at like when I was at home. That's why I had this problem.
Rules are rules, okay? These are certain guidelines which you should abide by.
Okay, ma'am.
Okay. And what do you think is a drawback of your study?
The population size, ma'am, because the population of Kuwait is 4 million, whereas in India it's in billions, so it's not comparable. So I feel that the results are not conclusive of anything.
Yeah. So it's not representative. Okay.
Yeah.
Deepti ma'am, you want to ask anything?
Yeah, I just want to know, since it brought in and telemedicine, have you read the MCI guidelines for it?
Sorry, ma'am?
There is a MCI guidelines which has been released for telemedicine on the principles, what should be done and what should not be done. Have you read it, Daphne?
No, ma'am.
You should read it.
Yeah.
Yeah, okay. Because see,
Okay.
Kuwait and India are two different places. If you want to compare Kuwait, probably you're required to take people who are from city, like for example, Bangalore, who are connected to internet, and what they think of e-health services. So you're basically covering pairing apples and oranges, right? So I mean that is the point in your study. If you can do it better with ethical clearance, like Dr. Chetana has mentioned, I think it will be good, right? You can still do it, continue doing it.
Yeah.
And with a good
Okay,
sample
ma'am.
size. 50 in Kuwait, 50 in India is just not okay, right? Scientifically, it's not fine. Okay.
Okay, ma'am. Thank you.
Yeah, good study. Daphne, continue doing such research. All the best.
Yeah, sure. Thank you, ma'am. Thank you.
Good luck.
Thank you.
Thank you, judges, for your very insightful advice on this. And Dr. Chetna ma'am and Dr. I'd like to tell you that two participants, catch ID 0096 Anupriya Kushwaha and catch ID Banushree J, will not be participating in today's event. So we are
Okay.
just one more participant in today's session, ma'am. Catch ID 0308 Yashika Gupta. Yashika Gupta, ma'am, are you here?
Good afternoon, judges. I'm Yashika Gupta, an intern working at Gadag Institute of Medical Sciences. If you could just...
Can you just take off your mask? You don't require a mask while presentation. So that we can hear you more clearly.
Hello?
Can you speak a little loudly, ma'am? You're not very audible.
Hello?
Yeah, that's
Am
better.
I audible now? Yeah.
Yes, yes. Ma'am, would you like us to share your presentation or would you like to take control and share screen?
Could you please share my presentation?
Yeah, just give us 1 second.
Yeah, thank you.
Is the presentation visible to you, ma'am?
Yeah, please, thank you. Good afternoon, judges. This is Yashika Gupta, an intern working at Gadag Institute of Medical Sciences. So we did a study. The title of the study was Prevalence and Factors Associated with Menstrual Disorders Among Undergraduate Students of DGM Ayurveda College in Gadag. And we did a cross-sectional study. Next slide. Menarche is the most striking event in the whole process of female puberty. The normal cycle depends from 21 days to 35 days in length, and the flow is 7 to 3 days, and the amount usually 20 to 60 ml. And anything that deviates from the normality is known as menstrual disorders. Almost every woman does experience one or the other type of menstrual problem in her life. The prevalence of menstrual disorder has been recorded as high as 87%. Next. Next slide. The disorders in cycles or its irregularities are major gynecological problems.
Yashika, you're not audible at all.
Hello?
Yashika, you're not audible. I would either you come nearer to the laptop or you have to speak louder.
Okay. Can you hear me now?
Yeah, this is better.
Okay. The disorders in cycles or its irregularities are a major gynecological problem among women in their reproductive years, and it causes a lot of anxiety to them and their family. And the most prevalent among them is excessive uterine bleeding. Dysmenorrhea is also one of the most common symptom and cause of school absenteeism among adults. In the WHO reported that 18 million women aged between 30 to 55 years perceive their menstrual bleeding to be excessive. Such disorders not only impose health problems but also limit attendance at work and school, which also hinder academic achievements and employment prospects. Multiple menstrual disorders have multiple etiologies, and studies of associated variables have found relationships with diet, eating, exercise, BMI, stress, and chronic diseases. Next slide, please. So the objectives of this study was to study the prevalence of menstrual disorders and to assess the factors which related to these menstrual disorders. Next. The study design was a descriptive cross-sectional study, and it was done in BGM Ayurveda College of Gadag. 125 undergraduate students were selected, and the study was conducted between 26th May to 9th June. We already had a pre-designed questionnaire, and we provided them to the students and they filled it, and we had collected their anthropometric measurements according to WHO guidelines. Statistical analysis was done using EPI Info 7 software after being tabulated on Microsoft Excel sheet. Next slide. So the results showed that the prevalence of menstrual disorders was as high as 94.4% among the undergraduate students. Next. The conducted study showed that dysmenorrhea accounted for the highest amount of menstrual disorders in those 125 students. It was 84.4%. Next was premenstrual syndrome, which accounted for 76%, and other menstrual disorders, which accounted for almost 10 to 20%. Next. In our study, physical activity was significantly associated with menstrual disorders. Other factors such as, we also assessed other factors such as stress, BMI, age at first menarche. Next slide. So we, in the end of our study, we found out that the prevalence of the menstrual disorders in DGM Ayurveda College was as high as 94%, and the highest proportion suffered from dysmenorrhea, as high as 84%, and also that physical activity was significantly associated with menstrual disorders. We recommend that students should be educated on the use of non-prescriptive analgesics for effectively controlling symptoms of dysmenorrhea and other various strategies for management. Students should be counseled on the importance of physical activity, diet, stress, and weight management. They should be encouraged to seek medical attention to rule out or treat if any underlying disease process which may be responsible for the menstrual disorders, which may later on interfere with the reproductive health in the later years. Thank you. These are my references.
Over to you, judges. Ma'am, you can start your questioning.
Why did you check the anthropometry of these girls?
To check if BMI was, if there was any specific correlation between BMI and menstrual disorders.
Did you find any?
No, ma'am. In our study, we did not.
Why did you think that BMI is associated with menstrual disorders?
In cases of obesity, they might, they have a higher chance of having polycystic kidney disease, so they might have irregular cycles.
Did you say polycystic kidney disease?
Ma'am?
Kidney disease, is it, Yashika?
So polycystic ovary disease. I'm so sorry, ma'am.
Yeah, okay. Okay, fine.
Yeah.
Okay, and see, in your study group, the prevalence is so very high. What is the prevalence in general population?
According to few other studies that were noted, the prevalence was found between 60 and 90%, ma'am, in other studies.
So what is that you're going to do in this Ayurvedic college?
Ma'am, we want to educate them about the use of non-prescriptive analgesics and how they can manage their periods and effectively so as to reduce the stress that they go through during each menstrual cycle. And
Did you
also
do
to
that?
visit. Yes, ma'am. We counsel them after the study, ma'am.
What about a gynecologic examination of them?
Ma'am, we encourage them to visit the healthcare professionals in case of any emergency or to rule out any underlying disease process.
But have you referred them to your hospital?
No, ma'am.
You should do that. You cannot use a group just for a research and then just leave them. If required, if a lot of them have dysmenorrhea, they're required to be seen by a gynecologist. And since you have found it with such a high prevalence among this group, I think it's ethically important that you treat them properly, right? So I think that is what you have to do because I mean, Ayurvedic college is different from your college. So I think you should refer them and make sure that they all get treated. Okay.
Yes, ma'am.
Okay. Chetna, you want to ask?
Yeah. Yashika, you're an intern, is it?
Yes, ma'am.
Okay. This study was done in 2017. Data collection happened in 2017, right?
Yes, ma'am.
You have a institutional clearance for this?
Yes,
Ethical
ma'am.
clearance?
Yes, ma'am.
Okay. So you're presenting it in bits and pieces, I believe. No.
Ma'am?
This is the only presentation that you did out of
Yes,
it.
ma'am. Yes, ma'am.
Okay. Okay. Then you have asked questions on physical activity, right?
Yes, ma'am.
How is it related to menstrual cycles?
Ma'am, people who had mild or moderate form of physical activity, they suffered from more menstrual disorders according to our study, ma'am.
Can you repeat?
The participants who had mild physical activity suffered from more menstrual disorders, mild and moderate.
Do you know the classification of physical activity or just you're guessing? Do you know or not?
No, ma'am, I don't know.
Then how did you assess physical activity? What's advice for this particular group?
Advice, ma'am?
What is the advice for physical activity for this particular group?
Ma'am, I don't know.
Then how did you do the study? Moderate activity of at least 75 minutes per day, 30 minutes a day, 5 days a week, that is 150 minutes of physical activity with 2 days of weight training. That's the physical activity that is advised. Okay.
Yes, ma'am.
And did you give any, you just put your recommendations. Did you do anything according to that for those students?
Yes, ma'am, we counseled them, ma'am.
How did you
Counsel all
counsel?
of the students. We told them about the non-prescriptive analgesics that they can use, like paracetamol, before and during periods to relieve dysmenorrhea pain, and in case they have excessive bleeding, that they should visit their health care providers.
Mm-hmm. You said that physical activity is very much important and related to the menstrual cycles, right? Did you advise them on that?
Yes, ma'am. We help them
What?
to do some form of activity every day, ma'am. At least 5 to 6 times a week, ma'am.
You should be very specific. Okay, you should be very specific when you give advice based on the group that you are targeting. Okay, for that particular age group, there is some criteria that WHO gives. You could have told them that. Okay, and you said that 60 to 90% is the prevalence of menstrual disorders in some other study. Can you tell me from where these studies are?
Yes, ma'am. It's there in the reference, ma'am. I have.
These are from which place?
Ma'am, I have not written down the place, ma'am.
Is it from India at least?
Ma'am, one of the two studies are from India, yes.
Okay. Please remember when you take some references, no, it should be representative or related to what you are doing, not some other country's data. Okay, that's what I was trying to tell. And your presentation should be very crisp, and the number of lines of sentences that you put on the PPT is also important, right? Not whole sentences with full stop, comma, the, everything. Okay, you should improve on that. Okay.
Yes, ma'am.
Good luck.
Thank you, ma'am.
Yeah, from my side. Thanks.
Yes, ma'am. With that, we come to the end of this session, ma'am.
Thank you, judges, for making this session very insightful, and it was very enlightening to hear all your thoughts. And thank you for your valuable feedback and your guidance. And we and all the participants learned a lot from the session, and I'm sure you also would have learned a lot.
Thank you so much. Wish we could hear the other two presentations
Yes,
also.
ma'am. Unfortunately, they couldn't hear
They
today.
couldn't make it, but anyways, thank you so much for making time for being here, ma'am.
And thank you to the
Thanks a lot.
participants.
Thanks a lot. Guys are doing a good job.
Thank you, ma'am.
Thank you.
And how do we give these marks?
Ma'am,
This marks.
you can enter the assignment digitally in the Word document and mail it back to the same address. If you have written
Sorry,
it down, you can
Deepthi,
scan
right? Yeah, just we couldn't hear. I couldn't hear what you said. You want me to enter it in the Word document?
the Word document and back to the same email ID, ma'am. That's
Acha, ठीक.
yes, ma'am.
Okay.
To the CatchCon
So,
email ID.
yes,
Sure,
our
sure.
department will receive it.
Okay.
Okay.
Thanks.
Thank you. Thank you.
Thanks.
Bye.
Thanks a lot.
Thank you,
See you,
Deepika.
Chaitanya.
Thank you, Chaitanya.